Thank you.
Shall I start, Sirisha?
Yeah, so Dr. Shanta, welcome you all for this wonderful meeting this evening. We have a great team and a great program to look forward to. I would like to call upon Dr. Shanta, who's the president of the Indian Pediatric Glaucoma Society, to welcome everybody.
A hearty welcome to you all. It's fantastic that we have such a great faculty, international and national, who've taken time off their Sunday, the relaxing schedule, to join us for this evening. There seems to be a veritable feast of glaucoma cases and presentations for us to listen to. So without much ado, I will pass on the baton to Dr. Sushmita Kaushik, who is the professor at the Glaucoma Services at PGI Chandigarh, and she will start with the introduction of the faculty.
Unmute, please, Sushmita.
Thank you, ma'am. And it's my proud privilege to kickstart this very interesting meeting. And the first session, as you know, is a sort of genetics primer because it's available so easily and all of us have greater access to it. So we have Dr. Ms. Ria, who's a genetic counselor at Shroff Charity Eye Hospital, Daryaganj. She's done her master's in human molecular genetics from Imperial College London and her BSc genetics from the University of Liverpool, Edinburgh, and currently is pursuing her PhD. And she has a keen interest in rare inherited and ocular diseases. And we'll follow that up with Dr. Gora, who is a well-known pediatric ophthalmologist at the L.V. Prasad Eye Institute. But in addition, she is also a fellow of ocular genetics from the University of Rochester under Professor Alex Levin. So she would be talking to us about what to make of the report, which we get. And we'll follow this up in the end by an overview of visual rehabilitation for children, because that's what, at the end, we're all here for. And we'll have Dr. Sumita Agarkar, who is Joint Director of the Pediatric Ophthalmology and Strabismus Services at Shankara Nethralaya, Chennai. And she's also a lead researcher with the Orbis International in India. So without much ado, Ria, we are waiting for you to tell us what, when, who, why to test, and what do we do?
Yeah. So before Ria starts, I would just quickly like to introduce our international guests as well. So we have Professor Arif Khan, who's the Chief Pediatric and Neuro-Ophthalmology Specialist from Cleveland Clinic, Abu Dhabi, who's with us. I think people who are looking at pediatric glaucoma, or rather pediatric genetics, every one of them would know him. So he's going to share his experience and help us to understand the genetics part of it and possibly integrate it with the clinical part of it in this meeting. I'm looking forward to your comments and your suggestions, Dr. Khan. And we also have Professor Nader Boyoumi from Egypt, Alexandria University, Egypt. He has done multiple fellowships in Switzerland, and he was with us with L.V. Prasad, I think maybe about 10, 15 years ago, and he specializes in pediatric glaucoma. So they do a lot of different types of surgeries. I would say a lot to do with deep sclerectomies and very surgically innovative team. So we would like to hear from you and learn from you as well, Nader, and please, we welcome you. Yeah, and we have Teresa Chen with us, Professor Teresa Chen, who's from Harvard Medical School, Mass Eye and Ear, Boston. Teresa is a great friend. She's fantastic. She takes care of the adult as well as pediatric glaucoma, and a lot to do with the ocular imaging, which she's been first in several things. And there are a lot of things that they do back home, which I think they can complement us and help us to understand whatever we are doing better as well. So welcome, Teresa. And so many of our friends from India. Dr. Mandal is here. He's the father of pediatric glaucoma. All of us have learned from him. Professor Ramakrishnan has joined us today. Welcome, sir. Welcome, Dr. Mandal. Welcome, Dr. Ramakrishnan. And we have a whole lot of guests here. Vinay is here. Vinay is the founding president of Indian Pediatric Glaucoma Society. So we should thank Vinay, Sushmita, and some of us who actually dreamt of having this group, and it is a reality today. And we have several other friends who have joined us as well. And now I hand it over to Sushmita, please.
So, Ria, all yours. The stage is set. Share your screen, please. Thank you.
Are my slides visible and am I audible? Is it full screen? All right. To start with, thank you so much, Dr. Sirisha, Dr. Sushmita Ma'am, Dr. Shanta, Dr. Vinay. Ipgs has been a very important part of learning and teaching, both for the past years that I have been in the genetic counseling profession. So thank you for the invitation. I'll jump right into it. My topic is genetic counseling, and I'll try to answer all these questions to the best of my ability. So, okay. To begin with, let's get into what genetic counseling is. So it's a very interesting guidance process of speaking about genetic disorders to layman. It is done by professionals who are specialized in genetic counseling, and they are often genetic counselors. Sometimes it's also carried out by clinical geneticists or specialty doctors who have done further training in genetics itself. As a genetic counselor, there are a few roles you entail. You provide information about how a genetic condition could affect an individual or a family. You also interpret genetic test reports for families. You convey information in a simplified manner to address the concerns of the family. And you end up meeting one family over multiple sessions, multiple times, so that they can make an informed decision themselves. And one of the key aspects of genetic counseling is being non-directive, which is giving all the options to the family and letting them choose what they feel is best for them. And of course, also the other aspect, apart from the technical know-how being passed on to the families, is providing psychological support to help them adapt to their condition. So there's often a lot of guilt attached when there are adults who feel they have passed on a condition to their offsprings and so on. So there's a lot of emotional and psychological counseling also involved. In the Indian aspects, there's certain aspects I'd like to talk about that also get very important to discuss in genetic counseling. For example, here we have to be culturally very sensitive. While it might be common practice in certain parts, in the certain Western nations, to offer termination of pregnancy as a first line in certain sections in India, for example, certain communities in South India and certain religions don't allow that. And one has to be sensitive when speaking to patients and respect their decisions about it. Consanguinity is also practiced in India that has to be kept into mind. Another thing we observe when we are training for genetic counseling versus when we are practicing for it is the individualistic versus familial approach. In this, while we do feel that the person who is suffering from a genetic disorder should have complete and sole right as to what and how they want to proceed about the disorder, be it testing or informing other family members about risks. That is not the case how it happens. Very often you will have multiple members of a family walk into your clinic, and in a cumulative decision making will occur in that session where the parents and grandparents, sometimes in-laws, will have a lot to say about the decisions to be made. The other aspect is the limited awareness and accessibility of genetic specialists, and as well as the facility of genetic counseling and testing. In India, we do not have a centralized healthcare system, neither does our government fund genetic testing or other tests. So a lot of things come out of the pocket of patients themselves. Oftentimes, because of which we find ourselves making recommendations about tests that might not be the best line of action, but is cost effective for the patient, so that we are able to reach the answer we are looking for sooner than later. And there's a lot of socioeconomic disparities within the populations that we serve. And so how does a genetic counseling session look like, and how do we proceed? So it is ideal to always obtain a 3 to 4 generation history. Focus on glaucoma and unexpected vision loss if you're talking about pediatric glaucoma. Focus on syndromic features. This is what a 4-generation family pedigree looks like. There are conditions in pediatric glaucoma in which genes are affected that have had implication in adult onset glaucomas. So an age-related glaucoma history in such cases also becomes relevant and can prove that the glaucoma is indeed hereditary. The other thing that pedigree charting does is that it helps you identify other individuals that are at risk. So if the age of onset of the glaucoma is slightly into early childhood or pre-teens, and there's a newborn child, it can help you screen them more regularly in case it's the kind of inheritance pattern that can affect multiple members in the generation. It can also serve as a guide for genetic testing. Whether one should go for single gene testing, for example, PAX-related aniridias, or one should go for broader, larger panels that cover more genes, or in some syndromic cases like 6p deletion syndrome, which has hearing loss, intellectual disability, along with pediatric glaucoma, if one should go for chromosomal microarrays, which helps you look at larger gene deletions and duplications. The other implication is, of course, also in research. It helps you understand, for example, if there's any linkage between different phenotypes that is being observed within the family, and you can note that down. The other thing that becomes very important is to have a holistic view in the genetic counseling session, apart from the pediatric glaucoma that for which the patient has been referred to you. Have a look at the medical and ophthalmological history of the child, include age of onset, laterality, view all medical reports, and make note of anything that could point towards a syndrome. How this helps is that it helps you provide targeted education rather than speaking about the disorder in a more broader sense. Once you have a genetic report, you can speak about the nature of the mutation. One can counsel about the recurrence risk, that is whether to more children for a couple or children of the affected individual. You can provide screening recommendations that can help manage the condition better, and prognosis in certain cases as well. And who are the individuals that need genetic counseling in this particular context? So your early onset and congenital glaucomas, example, pediatric congenital glaucoma and JOAG. These individuals, whenever there's a family history of glaucoma, one finds syndromic associations like the cafe au lait spot in this particular picture. Whenever there's unilateral glaucoma with development anomalies like in anterior segment dysgenesis, if there are young parents who have an individual who have a young child with a disorder and they are planning to have more children, genetic testing to speak about prenatal option becomes important. In order to interpret genetic test results, one needs the expertise to interpret the reports, which Dr. Gora will be speaking about as well, and clarification of diagnosis in some cases as well. With that, I'll jump right into a case to give an example. So this is child X that presented at 5 months of age in July 21 with a history of primary congenital glaucoma that was diagnosed elsewhere at 1 month of age because of corneal haze noted by the parents. TRAP plus TRAP was done again elsewhere in March 21, and the child was on medication. However, persistent corneal haze in both eyes was present and nystagmus. So at presentation in July 21 to us, the child had bilateral diffuse corneal haze. The corneal diameters were okay and there were no HAPS-TRI. IOP by eye care was 22 and 24 in right eye and left eye. The fundus was not visible and AGMs were stepped up. After 2 weeks, the IOP reduced to 19 in both eyes, and the corneal haze also reduced slightly, but it was still there. So in August 21, an EUA was performed in which the horizontal corneal diameter was noted, axial lengths were noted, and IOPs were noted. And diffuse corneal haze was assumed to be more in the right eye than the left eye. Again, no HAP trial were noted, and the bleb were well formed in both eyes. So based on these findings, a possible diagnosis of primary corneal disease of shed was considered, and the parents were counseled accordingly. The vision with Leah chart was right eye 2300 and left eye 2600. There was no significant refractive error. Nystagmus was persisting, and child had started going to play school, and he was uncooperative any further. That's about the clinical history. Now about a little bit about how the parents were doing through all of this. They came to us in the genetic counseling clinic, and they kept telling us that we feel that our child was earlier diagnosed with PCG, and now the doctors are saying that it's likely to be shed. Which is it? And despite a lot of persuasion that at a younger age, both the phenotypes can look overlapping and it can be hard to tell which is which, that was not a satisfactory answer for the parents. And they wanted to know in one go what it could be, in which case we told them, okay, we recommend genetic testing and maybe the genes can sort it out for you. And this is the kind of report we obtained. So we did obtain a report with a genetic mutation in SLC4A11, which is a well-known gene for causing shed, with in some cases also perceptive deafness, but that was absent in the child as of now. But what was intriguing again about this particular report was that SLC4A11 causes disease in the autosomal recessive fashion, which means in terms of zygosity, both the allele should have a pathogenic or likely pathogenic mutation. But in this case, the gene was heterozygous. And we were sort of back to square one whether to consider this or not as the reason why the child is getting the problem. Because the phenotype matches completely, we were leaning more towards accepting this report. So what are the possibilities we could have explored in such a case? We could have considered that this could have been a compound heterozygous mutation. And we asked the lab to recheck the analysis, look at the bioinformatic pipelines again, and see if there's a second mutation that was missed. And they reverted back saying that there was no mutation that was missed with the same results. The other was digenic mutation. If there is anything happening in any other gene that is known and related with glaucoma, bitratic glaucoma, that could be in this particular condition, but nothing showed up again. And we tried to look up if there's been reports of SLC4A11 acting and causing disease in the heterozygous state in some rare conditions. Again, that's something we did not find. And there are a few reports in which there's late onset FECD that a heterozygous SLC4A is known to cause. But as we know, the clinical picture of an FECD patient will look completely different. So we do feel we are stuck in this particular case. But the reason I chose to present this case is also to highlight the psychological impact of all of these findings for the patient. At first, they were perplexed as to what is the diagnosis for the child. This was their first child, as was highlighted in the pedigree. They were also hopeful that from the genetic testing report, they will be able to understand the risk of having the same disorder in the next child. And that's something we could not really help them out with still. And of course, because we made a recommendation for whole genome sequencing, monetary issues also came into the picture with the patient. This is another case. I'll be quick about this. This was a child with photophobia at 4 months and complaint of whitish appearance over the cornea. That was noted at 2.5 years. The corneal haze made us diagnose whether it could be shed or congenital glaucoma. But when they came to the genetic counseling clinic, we also started looking at other features of in the child. There was telecanthus, there was a depressed nasal bridge, There was bulbous nose. There was a long philtrum, scaphocephaly, which is a narrow and broad head towards the back. There was a short stature for the age, short neck. As you can see in the picture, the chin is almost touching his chest. The neck is almost invisible. There was a combination of bent of the back with a kyphoscoliosis and a small chest that was noticed. Immediately, a clinical phenotypical diagnosis of mucopolysaccharidosis was made. And in order to further classify it, we thought that it could be a Morquio syndrome patient. And I chose to highlight this case as the second one to emphasize that the test that could be performed to confirm this diagnosis was just doing urinary CADs, which is a 2,000 to 3,000 rupees test that can be easily done at a lot of labs. And once it is confirmed that it is an MPS patient, one can go more specific with the enzyme assays to subtype, and enzyme replacement therapy is also available. So not all genetic diseases go without any kind of treatment. And mutation identification in such cases is only needed in case of ambiguity, if there's confirmatory testing required, or there is prenatal context. So the take-home message from this is that genetic counseling is integral to comprehensive care. It becomes very important for the clinical staff to clinical team to work with genetic counselors hand in hand. And family history and genetic testing play a key role in genetic counseling sessions. Counseling must be culturally sensitive and non-directive in all cases. And a multidisciplinary collaborative approach is required to take care of these often syndromic patients that are identified, and early diagnosis and screening can save vision.
Yeah. Thank you, Ria. Thanks a ton.
Thank you.
I was going to stop you before case 2, but it was so interesting, I couldn't stop you. I'm sorry. But anyway, so Dr. Arif, you'll have to jump in with both of them.
I don't know how much time we have.
Yeah, about 2 to 3 minutes. So we'll just, especially the first one, because autosomal recessive heterozygous matching a phenotype is.
Well, let me just say, first of all, Ria, I really appreciate the work you do on the work that genetic counselors do. It's a tremendous field. It's so important, and it's so challenging. So congratulations to you.
Thank you.
I think I'll start. I'll have 2 points to make. I'll start with the CHED patient. CHED and congenital glaucoma, both of them are clinical diagnoses. They're not genetic diagnoses. We don't need genetics to make those diagnoses. For the CHED patient, I know that you referred the patient, but you can make the diagnosis. A newborn who comes in with corneal haze as a newborn that's significant, there has to be some degree of ocular enlargement if it's congenital glaucoma because it started in utero. And if you certainly can have cases that are difficult to discern, but if you follow them a little bit and you see that the cornea is not enlarging, the axial length is not enlarged, look at the pachymetry. I don't know if you had the pachymetry data. You can make, and also the haze in CHED is different than the haze in congenital glaucoma. It's the clinician's job to make that diagnosis. It's not, oh, we'll send it for genetics and let them tell us. No, it's the clinician that makes the diagnosis. And then the genetics is confirmatory and can help with family planning. Now, whether or not you find the mutation as SLC4A11, that is CHED. I assume. I didn't see the patient, but let's say all the features are there. We diagnose it phenotypically. The fact that you found one variant suggests to me that on the other allele, there's a deep intronic variant, or there's a promoter variant that's just not detectable by our current means. But the not finding it, even if you didn't find any, I would still, there've been many situations where we've been very, very clear, positive about the phenotype, and there's one gene related to the phenotype, it comes back negative. We put them in a research protocol, something more advanced, and we find a hidden mutation that was not identified. If you did RNA sequencing or something like that, I think you would find it. So I think this is a very important point. We don't rely on genetics to make clinical diagnosis. We make the clinical diagnosis, and then genetics supports us.
Yes.
The other thing I would like to say is, you made very good points, but there's one point I maybe disagree with a little bit. You mentioned indications for genetic testing, and one of them you said was unilateral glaucoma. Now, with developmental abnormality, in my experience, the yield for that is very low. Now, you can certainly have asymmetric disease, and certainly there are some unilateral cases where you do find a genetic cause. And whenever you have a unilateral case, you have to worry about things like neurofibromatosis, Sturge-Weber, something causing a secondary glaucoma. But in general, if you have isolated, not a secondary unilateral glaucoma, in my experience, the genetic yield is very low. So, but yeah, and what you do is so challenging. I don't know how, what kind of time you're allocated to do what you do, but it's so challenging to do all of the things that you do in a efficient amount of time. I'd be curious to know how you manage that.
Yeah, so it is.
I mean, how much time are you allocated to a patient when you have a patient?
Approximately 40 to 45 minutes. It does, because just the family pedigrees take about 20 odd minutes, and then because in general patients we get, I mean, even in developed countries for that matter, people don't know about genetics much. So toning out the language and just conveying the information, getting everything out from them, it does take that time. So 40 to 45 minutes is a good average for each patient.
I mean, I think it's challenging even to do it within that amount of time.
Yes, agreed.
Thank you. I'll stop talking. Thank you very much.
Thank you. Well, just to set the clock running, we'll invite Dr. Gora. If you could share your presentation and help us make sense of the report. Dr. Gora, all yours.
I hope my slides are seen. Good evening, everybody, and thank you, Ipgs and Dr. Sirisha, Dr. Shanta, for inviting me to give this talk on decoding genetic reports. And thanks, Ria, for that background, and you made my job a little easier. So during this next 15 to 20 minutes, we will understand the basic terminology that is presented in the genetic reports, and we'll also understand the reports through a few case examples, and also understand what a negative report means and how do we interpret that. So this is how a normal genetic report looks like. So this is this I have taken a screenshot from one of the report of one of my patient. The first column is usually the gene, and then the DNA change and the protein change is depicted, followed by the zygosity, which Ria was alluding to, whether it could be heterozygous or a homozygous, and the disorder that this gene is associated with, and in what inheritance pattern that this condition is inherited in, and the final column is usually the ACMG classification for the reported variant, whether it's a pathogenic, likely pathogenic, or an uncertain significance. In the next subsequent slides, we will understand each one of these in detail. So as we all know that we all are diploid organisms with 23 pairs of chromosomes, of which 22 are autosomes and 1 pair of sex chromosomes, in females which is X and X, and in males it is X and Y. And we all carry 2 copies of the genes, one inherited from our father and one inherited from our mother. And each genes have exons and multiple introns. Due to this diploid nature of our chromosomes, there is inheritance pattern. So the most common one is the autosomal recessive inheritance pattern, where if the parents are heterozygous, that is, they are carriers, they do not manifest the disease, and the disease is only manifested when both the alleles of the genes are affected. And there is a 25% risk of the child having the disease if both the parents are carrier at each pregnancy, and 50% risk of the child being the carrier, and 25% risk that the child may be normal without even being a carrier. While in an autosomal dominant inheritance, there is 50% chance for each offspring that the parents can have with one affected parent. The next common inheritance pattern is the X-linked inheritance, where a male transmits a disease to his grandson through a carrier female. So that's how the X-linked recessive inheritance happens. And the other inheritance patterns that we usually see are the mitochondrial mosaicism, the somatic mutation, Y-linked, and the very rarely uniparental disomy. So we all know the central dogma, that is DNA to RNA to protein. So DNA replicates upon itself to form the second copy, and it transcribes to form the RNA, and the RNA is translated to the protein. So as you can see over here, these are the DNA nucleotides that are arranged, and this is the transcribed mRNA, and 3 of the nucleotides form the codon to code to a specific protein, amino acid, sorry. So as you can see over here at the position 4 depicted in this picture, where it's usually a G, when G is replaced by an A, there is a corresponding change in the mRNA to U. So in the first picture, you see the CAU codes to histidine, while in the second picture, it is changed to UAU, which causes tyrosine. So this causes a change in the structure of the protein, and that affects the function of the protein. And this is how the genetics work. So what are the kinds of genetic changes that are reported? So there could be chromosomal changes, which could be duplications, deletions, inversions, or translocations, or there could be a single nucleotide changes, such as a missense change, or a nonsense change, or a deletion and an insertion of a nucleotide, which can cause a frame shift and also a splice-altering site. So let's come to the next concept, that is the zygosity. I think Ria made it very clear. Like for an autosomal recessive inheritance disease to manifest, there should be both the alleles of the gene should be affected. So when the same variant is present on the 2 copies of the genes, it is called as homozygous. When only a single variant is present on 1 copy of the gene, it is called as heterozygous. When there are 2 different variants that are present on the opposite copies of the genes, we call it as a compound heterozygous. So for an autosomal recessive disease to manifest, it has to be either in the homozygous or in the compound heterozygous state. So when you have a 2 or more variants reported for a gene, so what are all the possibilities that can be present? So maybe the 2 variants are present on the same copy of the gene, could be either maternally or paternally inherited. In this possibility, the autosomal recessive inheritance becomes a less likely condition, and this is called as a cis configuration of the alleles. While if the 2 variants are present on the opposite copies, it is called as a trans configuration, and this is required for an autosomal recessive disease to manifest. And how do we identify if they are in cis and trans is by doing a segregation analysis in the parents. The last thing that we have to look into is the variant classification. In 2015, the American College of Medical Genetics gave the different criteria to classify the variant from the spectrum ranging from benign to likely benign to uncertain significance to likely pathogenic and the pathogenic variants. And this is all dependent upon the different levels of evidence that are present to ascertain the variant to be either a likely benign, likely pathogenic, or a pathogenic. If the evidence is not good enough to classify them as either likely benign or a likely pathogenic, it is classified as an uncertain significance. So what are the levels of evidence that are present? So we have population frequency databases, we have variant type, if it is a nonsense or a frame shift mutation, and if it is the substitution of the same amino acid to a different amino acid, then we'll have to look into the biochemical and the functional change that is happening at the amino acid level. And there are various prediction algorithms like the in silico protein prediction models, which will help us to identify if the structural change in the protein is going to affect the protein function or not. And as always, clinical data and the clinical evidence always has a very higher level of evidence. It's important to identify in the literature if the same variant has been reported with an affected individual. So that is how you can reclassify your variant based on the evidence that you can find. So with this information, let us quickly go through a few of the cases. So my first patient is a 3-month-old child who was presented to the glaucoma clinic with primary congenital glaucoma. And she was referred to the genetics because the parents wanted to plan for the next pregnancy and wanted to understand what the genetic condition that the child had. So, and the parents belonged to the same genetic community. So this child carried an homozygous, a missense variant in the CYP1B1 gene. And this is associated with anterior segment dysgenesis and primary congenital glaucoma, which is inherited in an autosomal recessive pattern. And this variant is classified as pathogenic variant. So this can explain the autosomal recessive inheritance pattern of the CYP1B1 associated congenital glaucoma. Let's see this case too, similar to what Ria was explaining about. So this child had, this is a child of a different family with primary congenital glaucoma, which was the phenotype that was provided. So on genetic testing, we found two missense variants on CYP1B1 gene, which were both pathogenic. So what are the possibilities at this point? So the possibilities that these two variants can be on the same side of the same allele of the gene, so that is a cis configuration, could be either on the maternal copy or on the paternal copy. But this configuration, the cis configuration, does not explain the disease. So these two variants have to be in the trans configuration for us to explain it's an autosomal recessive disorder. So how do we do this? By doing a segregation analysis in the parents. Let's see another case of a 2-year-old girl who was presented with primary congenital glaucoma, and there was no affected family members, and there was no parental consanguinity, and this is the clinical picture that was presented. So the genotype, the gene testing was done, and as you can see, which could be a possibility where you see two or more than two variants for the same gene that has been reported. So here you can see that there are three missense variants present in the CYP1B1 gene, which were heterozygous, and the variant classification was the uncertain significance. So on reanalyzing the data, we could find out that the first variant was still uncertain significance, but the other two variants are likely pathogenic variants. But having said that, we still need to do a parental segregation analysis to identify if these are in cis or in trans configuration. Sometimes we also have a possibility of a complex allele when there are two variants present in the cis configuration can affect the protein structure change than just being in the trans configuration. So it's important for us to identify here if there is a presence of a complex allele and also the configuration of these variants being in either cis or trans. Let me take you through another case of a 15-year-old boy. Sorry, pardon me, the clinical picture is both of the left eye. I just forgot to put the right eye picture. So it's a similar symmetric condition. So he was diagnosed with glaucoma and was on treatment. His current intraocular pressures were 25 and 21 millimeters of mercury. And his elder sister was affected with a similar condition. There was no parental consanguinity, but the parents belonged to the same genetic community. And he did not complain of any nyctalopia. So this was his clinical picture. So he had an almost 0.9 cupping, and there were pigmentary changes in the posterior pole, and there was also this scar. This scar was due to the retinal detachment surgery that the patient has had. On posterior segment evaluation on the OCT showed that there was intraretinal cystoid spaces and the subretinal fluid, which was diffuse. And also you can see that there was thickening of the ellipsoid zone, both in the right and the left eye. This patient was suspected to have autosomal recessive bestrophinopathy and was subjected for genetic testing. So this is how a genetic report looked for this patient, and it's not uncommon to find multiple genes reported in a single patient with a different phenotype. So here you can see the best one. There are two variants. The first variant is a nonsense change that is causing a stop mutation over here. And the second variant is a missense change. Both are heterozygous, and this best one disease in an autosomal recessive inheritance is known to cause autosomal recessive bestrophinopathies. And the first variant is reported as pathogenic, and the second variant is reported as likely pathogenic. So this is a genotype-phenotype match to our patient, but for us to understand the configuration of these two alleles, we need to do a segregation analysis in the parents. Also in the report mentioned was the RPE65 gene with a missense change in a heterozygous state, and RPE65 in an autosomal dominant condition, it's known to cause retinitis pigmentosa with choroidal involvement. It looks just like choroideremia, and this variant was classified as likely pathogenic. So there was no phenotype match. This patient did not complain of nyctalopia, but we still need to do a cross phenotyping for this patient, and patient will require an electrophysiological testing. The other, when we scroll down the report, the patient also was reported to have a missense change in his CYP1B1 gene. And since this condition, CYP1B1 gene is inherited in an autosomal recessive pattern, causing primary congenital glaucoma. So we thought that this is a less likely the genotype for this patient, but Dr. Arif was alluding to that there could be a deep intronic or a promoter region change in the other copy that we might have missed. Whether CYP1B1 and BEST1 are working together for the cause for glaucoma for this patient, we still need to identify. But at this point of time, we can call that this patient could be a carrier for CYP1B1 gene. So another case of a 3-year-old girl who presented with the megalocornea in both eyes with a corneal haze of grade 2 and elevated intraocular pressure. And she...
Gaura, you'll have to wrap it a little fast because we have
Okay, I think I'll be done in 2-3 minutes.
Okay, all right.
Yeah. And there is both eyes blue sclera was noted, and the child was having primary congenital glaucoma with no systemic features or parental consanguinity. So the genetic report shows that there was a missense variant in TEC gene, which was associated with autosomal dominant primary congenital glaucoma. And on D-analysis, we could reclassify the variant as a likely pathogenic variant. And there was another variant which was reported as PRDM5, which was homozygous nonsense variant, which is associated with brittle cornea syndrome in autosomal recessive. So the PRDM5 explains the blue sclera and the myopia, and the TEC gene explains the glaucoma. So it's not uncommon to have the co-occurrence of two different conditions in a single patient. We should always go with an open mind when we are looking at the genetic reports. So this is all about the positive results, but the most common thing is the negative result that we come across in patients with glaucoma who come for genetic testing. There are various reasons why we get a negative results. Probably we might have a wrong diagnosis. This is very less likely because the clinicians do the deep phenotyping and provide us the diagnosis. The second could be the wrong method of testing or a wrong sample. A sample swap can happen, or it could be an inadequate sample or a wrong gene, and probably the gene is not discovered yet, or there could be a deep intronic or the promoter region change that cannot be identified by the current testing methodologies, or there could be epigenetic changes. So I was just looking at the literature for the yield of genetic testing, and this report shows that there is 32% yield of genetic testing in children with glaucoma less than 3 years, and 5% in patients with later onset glaucoma, which was again confirmed by another study which showed that there was yield of 24%. So what does this mean? That this group of glaucoma, that you all have a huge opportunity for new gene discovery and genetic therapy targets in glaucoma patients. So I would like to end by this quote that alone we can do so little and together we can do so much. Thank you so much.
Thank you, Gaura. You reiterated the path that all of us, I think, go through. Dr. Teresa, Dr. Chen, your comments on her cases.
Yeah, thank you so much. I think these wonderful talks are a reminder to all of us that our colleagues are so important. I'm reminded of two things. I'm a glaucoma specialist. I see adult and pediatric glaucoma patients, but I think especially in my pediatric population, unlike my adult glaucoma patients, that genetics is so important. So these talks are wonderful. The second thing that I'm reminded of is that taking care of pediatric glaucoma patients is really a team effort. So I take care of the ophthalmology part and the glaucoma, but I have my pediatric ophthalmologists who help with the amblyopia care. But I'm also fortunate to have Mass General next door. If there's any atypical facies or systemic issues, I can refer them to Mass General for systemic workup and genetic workup, and of course, Boston Children's Hospital. So this is a great reminder of the importance of genetics as well as the team effort that we need for pediatric glaucoma patients. So thank you for the wonderful talks.
Okay, thank you. Dr. Bayomi, any comments, any insights?
No. I will add my voice to the speakers that of the great effort they're doing with the genetic counseling. I just want to make that small comment or perhaps a question, since you've raised cultural issues. How do you explain to the parents the concept of probability? You know, as a man of science or people of science, we understand what is probability. That is, you can have a chance of having some pathology and you may not have it. Okay, so for lay people, could any one of our geneticists, colleagues, just tell us how on practical grounds do you explain the concept of probability? because when we tell this to our patients, they take it as a percentage of the disease. That is, for example, when I tell them you have a 25% chance of having a child with glaucoma, they understand that as we have a child that has glaucoma by 25%. You get that? So have you any clues about how to just explain this to our patients, our parents, I mean? This would be an excellent addition, please.
Dr. Gaura, you want to take it, or I'll?
Yeah, I just wanted to add that it's very important for us to explain to the parents that the risk is at each pregnancy, and it's not about the severity of the disease. Either the child, like the severity can vary because there could be a background genes that are working up. But it's very important for them to understand that the risk is at each pregnancy, whether it is 25% or 50%, depending upon the inheritance pattern. That has to be stressed to them, because there have been instances when the parents have been counseled the 25% risk, that is 1 in 4 children. So they go on to have 4 children, and they say that only one child you said will be affected, and now all 4 of my children are affected.
Exactly. This is just what happens at our place. Exactly.
Yeah, very true. And so that's one important aspect to pay attention to. The other thing that I do, if the patient really, if I think they are perceiving information well enough, I will just use a pen and paper, go back to diagenic inheritance, 2 copies, alleles, simplify it, tone it down, but I actually draw out alleles of the mother, the father, and how the 25%, and I'll draw the other 50% and 25 of the carrier and the dominant, and sort of start from there to explain it to them. But yes, the second point is so much more important to convey, that it's not like if it's happened once, the other 3 kids you're going to have are going to be fine. The risk is for each pregnancy. Yeah.
Exactly.
Dr. Arif wanted to make a comment.
Yes, if I have a moment to say something. First of all, I thought that was an excellent presentation. That was really well presented. Congratulations on that. I just have one question and then just a few comments. The question is, the patient with the glaucoma and the best one, was that an open angle or a narrow angle glaucoma?
That was a narrow angle glaucoma.
So you probably don't need another explanation because best one, the patients are quite hyperopic and they have narrow angles. So that, the best one in itself, I don't think you need to find another explanation if it was narrow angle. The comments that I wanted to make is, one thing is that many of the variants that are reported as pathogenic in the literature are wrong. Before it was more lax about reporting mutations and variants in genes as being pathogenic. But with time, we know that many have been proven wrong. So just because something is listed in the literature as being pathogenic, that doesn't mean that it is. Sometimes the mistake gets repeated. It could be a variant that's linked with something else. They happen to co-segregate. And it's that co-segregation that's the reason. It's the other allele. And that happens over and over again. So just because something is in the literature, it doesn't mean that it's true. The other thing I'd like to say is the prediction programs are not always right. We have seen patients where it's predicted to be pathogenic, a variant, and it clearly isn't. And again, it goes back to the literature not always being correct in these regards. So we always have to keep an open mind about this. And that's why the clinician is so important. I've been asked before, why do we even need clinicians if we can just do genetic testing? Actually, with all of this genetic testing, we need clinicians even more to phenotype and confirm, because you find all of these variants that you don't know what to do with. And the phenotype is even more important than it ever was before, because it's really the clinician correlating with the genetic findings that's the answer, not just the genetic. What you find in the DNA is just a finding in the DNA, but what the patient has is not necessarily a disease. As you mentioned, that patient with the RPE65 variant is not necessarily going to get that disease. There are many situations where you go out into the normal population, you can find variants in genes that are associated with disease in others, but in another patient, it might not cause the disease. That's because these variants don't act in isolation. They're acting in the context of the entire genome, and there can be other factors that are protective. So it's important to keep all of these in mind. I'll make one last point. Your presentation was excellent, But there's one other possibility when you were talking about the heterozygous and the compound heterozygous. There's also the possibility that the second allele is completely deleted and not being detected at all. And that would come up in segregation. But I'm just telling you that for completeness because you said these are the possibilities. They were the possibilities, but there's an additional possibility that the second allele is just completely deleted and the segregation would pick that up. So thanks for it. That was really good. I was very impressed.
Thank you.
Thank you. Thank you, everybody. And we move on to what we clinicians really want to do, get the best vision. Dr. Sumita will tell us where we stand with providing the best vision possible for these children. Dr. Sumita, could you share your slides, please?
My slides visible?
Not yet. Could
Not
you
yet.
share it? Yeah.
Okay, one minute. Is it okay?
Yes, it's visible. Thanks.
Okay. So thank you to Indian Pediatric Glaucoma Society for inviting me. This is a little out of thing, but I always believe everybody should know how to take care of amblyopia, irrespective of what specialty they practice. So let's look at a patient here who is, it's year 2003, and I'm introduced to him as a baby who's 3 months old, and parents have come with enlarged eyes and white spot in the eye. So corneal diameter roughly is around 13.5, intraocular pressure. This, of course, we did it under anesthesia. Intraocular pressure was 44 and 56, corneal edema, both eyes, have stripe present, more in the right. And my colleague, Dr. Vijaya, she did the external trab within a week of diagnosis. And everything went well. EUA at the end of 6 weeks, cornea is cleared. Horizontal corneal diameter is still around 13 and intraocular pressure is well under check. Refraction at this point was done, but not very much significant. Anyway, patient disappears. Cut to 2006. Now he's around 3+. IOP is still under control. Cornea is clear. Discs are healthy. But you can see here my notes at that time. He has a fair amount of anisometropia here, which when we repeated the cycloplegic refraction, you can see here that, and we put him on patching and glasses. And next he turns up at age 8, and you can see with even parents feel that compliance to patching is good, but you can see vision is 6/60 and N10. Cut to 2024. Now he has a small RXT, as you can see. Corneas are relatively still very clear. Discs are healthy. Intraocular pressures are normal without any medication. But his vision in the right eye remains 6/60. So finally, at the end of it, he lost vision not because of the glaucoma, but because of the amblyopia. So it's important that we talk about amblyopia. So this is a definition which is given in von Noten, that it is unilateral or bilateral reduction in visual acuity without any organic or a refractive cause. And it is secondary to abnormal binocular interaction or visual deprivation during a sensitive period in the visual development. So clinically, we can define as an intraocular difference of 2 lines or more, or best corrected visual acuity of 6/9 or less. In respect to childhood glaucoma, despite that definition, several organic factors can coexist in addition to amblyopia. These can be corneal scarring, anisometropia, sometimes advanced glaucoma leading to optic neuropathy, optic neural disc changes, each contributing and complicating amblyopia. But amblyopia remains an important cause of visual impairment in children with childhood glaucoma. So roughly in population, around 1 to 4% children, and large population studies have put it at around between 1.6 to 3.6%. And of course, it is higher in medically underserved population like ours. So these two gentlemen, these Dr. Hubel and Dr. Torsten, have led to our understanding of amblyopia greatly, and for which they received Nobel Prize of Medicine in 1981. And a lot of our understanding comes from their work in this area. So is there everything what we have known about amblyopia? Is it well understood? No. Factors responsible for visual development in the initial critical period are that each eye should get an adequate stimuli, there should be a corresponding retinal images, and there has to be an intact visual pathway to process all three together. So any disturbance in these inputs can lead to amblyopia, which in turn leads to not only structural modification of the visual neuronal circuits, but also produces actual morphological changes in LGN visual cortex. So amblyopia is actually so much more than just decreased visual acuity. Amblyopia is now considered a neurodevelopmental disorder. It is a binocular problem, and striate cortex or area V1 is supposed to be the most affected. So basically, we have moved from eyes to brain here. So in addition to poor vision, there is loss of binocular vision. There is decrease in contrast sensitivity, motion processing, audiovisual processing, spatial audiovisual localization, and decreased vernier acuity. And we now find that these higher order deficits, which we do not normally check, also extend to the other eye, the eye with the good vision. So it's important that we consider it as a binocular problem rather than a monocular visual loss. So these are the types of amblyopia classically defined. Workup for an amblyopia patient can include all these things, irrespective of whether the patient has congenital glaucoma or something else. You have to do all these steps here. So visual acuity is the most important parameter, and age-appropriate chart should be used. Children likely to perform better with a single optotype chart because of the crowding phenomenon, which is exhibits with the amblyopia. And simple single optotype chart can be used with a surround to mimic crowding and get good compliance from the patient. Of course, we forget to sometimes check near vision in younger children, and I think that should be done because sometimes that is something which recovers much faster than the distance vision. So these are examples of some charts which we can use. Comprehensive eye ophthalmic evaluation is important, and you have to definitely rule out any causes of deprivation, rule out strabismus, and fundus evaluation to rule out any posterior segment anomalies. And needless to say, cycloplegic refraction still remains most important part of the armamentarium. So what are we doing as management in 2024? So more things change, more they don't. So strategies of dealing with amblyopia remain same. You first need to clear media opacities if there are any, appropriate refractive correction, occlusion, penalization, or dichoptic or binocular therapies. And of course, we need to follow up these patients. So treat the cause is the first thing. Remove the cause of visual deprivation. If there is cataractosis or vitreous hemorrhage, deal with it. However, if there is strabismus surgery comes after amblyopia treatment and not as the first. Prescription of the glasses in itself is an amblyopia therapy. Pedic studies have proved that refractive adaptation alone means simple prescription of glasses can improve vision in mild to moderate amblyopia, and nearly 30% of the children no longer needed any amblyopia therapy at 6 weeks. So giving glasses reduces the burden of amblyopia and gives you a better start to occlusion therapy. So if you start with 6/60 vision, versus if you give glasses and vision improves to 6/18, chances of him going to 6/6 is much better because you're starting with a better pre-treatment visual acuity. And it also sometimes can avoid the trauma of occlusion in some selected cases like anisomyopic refractions. Now, if you look at the treatment, you have monocular therapies like patching or penalization or perceptual learning. You can have partly binocular, and then there are fully binocular therapies, which are more current thought process, which have relatively less data but definitely are options which we can have at this time. So George de Buffon was the father of amblyopia therapy because he was the first one to show the importance of patching in an amblyopic eye, and basis of patching therapy, he was the first one. So it still remains, despite being 2024, it still remains the mainstay of amblyopia therapy. And what we do in occlusion is either block the images or degrade the quality of images coming from the dominant eye or the better vision eye using either an optical mean or a pharmacological mean. It enhances the neurological processing of visual input from the amblyopic eye. Atropine drops have been used as a way of penalization or a pharmacological penalization of the better eye. So 1% atropine drops in better eye can produce a visual blur and image degradation, and it can be effective as 2-hour patching in some moderate amblyopia. Compliance is often better with patching and less obtrusive, and it also allows some binocular interaction. So probably works on taking care of some binocular deficits like stereopsis. And Ipgs studies also found that even if you don't put atropine every day and only a weekend atropine, it is as effective as daily atropine. So if you have, only thing is it probably does not work in very dense amblyopes, because even with degraded quality of the visual image in the amblyopic, in the better eye is probably still better than. So if your vision is 3/60, probably atropine is not your choice of treatment. Occlusion or patching remains the gold standard. However, there are lots of divergent views on how much to patch. So PDIG has helped us to rationalize much of the way occlusion is prescribed. However, one word of caution here, ATS results need careful interpretation before applying to clinical practice, because ATS did not look at deprivational amblyopia at all. And they have very, very, very carefully, results are tailored for depending on the visual acuity, whether it was mild amblyopia or moderate amblyopia or severe amblyopia. So you need to carefully interpret the results. So what do we know with ATS? That moderate amblyopes means visual acuity of 612 to 69 from age 3 to 7. 2 hours patching was found to be as effective as 6-hour patching. In the same age group, if the amblyopia was severe, means visual acuity less than 624, 6-hour patching had similar improvement as full-time patching. Sorry, I'm sorry about that typo there. So 6-hour worked as good as thing. And adding a near activity definitely helped. Can we treat older patients? Yes, we can. Between 7 to 13-year-old, even if there has been amblyopia therapy has been previously tried, you can still give a trial of patching. In older than 13 to 17, if earlier patching has failed, then probably restarting the patching may not give you any benefit. Now, behavioral treatments like perceptual learning, what is it? It is any permanent or a consistent change in the perception of the sensory task following repeated practice. So basically, it's a non-invasive, software-based, patient-specific and interactive software, which is available as a mobile app. Here, it is a monocular therapy because patient sits in front of the screen wearing the best optical correction and dominant eye is occluded. So you can teach patients on several tasks on perceptual learning. Several of these are mentioned here, like you can work on contrast, you can work on stereopsis, you can work on color, like that. So only negative part with the perceptual learning is tasks are repetitive, and sometimes it only improves proficiency in the task which you are, and may not, the benefit may not extend to the other tasks or visual acuity. Video games, several video games have been tried. Again, playing action and non-action video games with better eye occluded. Again, it's a monocular therapy, induces cortical plasticity and improves visual function. And they also induce a reduction of noise and increase in sampling efficiency. So they can be worth trying because several studies have reported looking at a control group have found effective improvement, but there is always an addiction potential, especially in children. Now, changing the focus from vision to binocular vision, because patching or any of the monocular therapies do not focus on binocular abnormalities like stereopsis or contrast. So the newer thinking is that we can do a binocular therapy like a dichoptic training. What is it? It is a contrast adjusted stimulus which is presented to each eye. The dominant eye gets more full contrast image, while the non-dominant eye gets non-contrast or low contrast image, and brain is forced to integrate it into one perception. The tasks in which stimuli are presented dichoptically with the contrast of the image, as I said, attenuated, and patient has to use both the eyes in combination to get the two inputs into a single image. So dichoptic stimuli are designed so that they are perceived binocularly. Then only the patient will be able to complete a task. So several games here, Digiraj.
Dr. Sumita, if you could just wrap it up.
This is the last two slides. That's all. So you can see the child wears anaglyphic glasses, red-green glasses, and he can see certain things with one eye and certain things with the. So to enjoy that game, he has to see it binocularly. Luminopia, this is a FDA-approved binocular therapy. It's a virtual reality headset, 1 hour per day for 6 days a week with correction in place. And this small trial showed definite improvement. Only negative thing about this trial was that it did not compare it with the conventional patching. So definitely a good improvement and good compliance with the patients was seen. This is basically a magnetic field generated by a plastic coated coil of wire placed on the head, which induces a weak electrical current that may stimulate cortical areas. Rationale for therapy using the drugs has been that dopamine has been found to reduce, and increasing the level of dopamine in the retina may have a beneficial effect. So these 3 drugs have been tried, and I have mentioned on the side the problems and the effects which have been seen with this. So to carry home, err always on the side of treating. So do not hesitate starting occlusion in asymmetrical disease, or if you suspect one eye is doing better than the other. And this can be done by anybody. As I told in the ATS study, a small amount of patching also works very well. So prescribe appropriate glasses and offer other therapy modalities if patient can have access and afford. But please do not, even if you are a glaucoma specialist, do not hesitate to prescribe glasses and patching to these children. Thank you very much for that.
Thank you. Thank you, Dr. Sumita. That was amazing. Dr. Shanta, any closing comments on the session? Dr. Anil
It was a fantastic session, and I think we learned a lot from each speaker. The complexity of the genetic components of disease in pediatric glaucoma and how to deal with it. So thank you so much. I think in the interest of time, we'll move on.
Yeah. So I'm happy to hand over the next session to you, ma'am, and take over, you and Sirisha.
Yeah, thank you. Thank you. That was a lovely session. So we move to the second and the more interesting one, because it is case-based, and I'm sure there's so much that we can learn. So I would invite the Teresa and the other panelists, Nadir Bayomi, Dr. Khan, Sushmita, Shanta, Vinay, Manju, Ria, Gaura, Dr. Mandal, Sunita, and Dr. RK. So let's start off with the cases. To begin with, we will have Parivadini, who will start with the first one. So the order, like I said, the order will be as is there in the program sheet. So Parivadini can start. So please stick to the time of the presentations. It's for 5 minutes, and then we can have questions at the end of every session for 2 to 3 minutes, and then we move on to the next one.
Thank you, ma'am. At the outset, I would like to thank the organizers of Ipgs for this opportunity. Are my slides visible, ma'am?
Yes, Parivadini, please go ahead.
So I'll be sharing our experience of managing a rare case of type 3 congenital fibrovascular pupillary membrane. So this was a 3-month-old female child who presented with enlargement of the left eye with constant watering. She was already locally started on 3 anti-glaucoma medications along with atropine eye drops. On clinical examination in the OPD, we could see that the right eye was normal. The left eye showed corneal haze, corneal edema, megalocornea. There was iris bombay. The lens was not visualized. Ultrasound showed that the lens echo was seen. The retina was on. However, the axial length was more in comparison to the right eye. It was 25 millimeters. So a 3-month-old child with corneal opacity, shallow AC, iris Bombay with raised intraocular pressure. We had all these differential diagnoses in mind. ROP and retinoblastoma was ruled out with the normal ultrasound. We proceeded with an examination under anesthesia with ultrasound by microscopy. The corneal diameter was increased. The intraocular pressure was 36 millimeters of mercury, and the axial length was more, which all showed that the increased intraocular pressure was there for some time in this child. The lens details were not seen. The UBM showed characteristic features. There was anteriorly pushed iris with iridocorneal adhesions in comparison to the UBM, which was done 16 days earlier, where centrally some anterior chamber was seen. Within 16 days, the UBM, which was done here, showed that the anterior chamber had obliterated, so which showed that there was rapid shallowing of anterior chamber. So with the child with secondary glaucoma with pupillary block, we proceeded with anterior chamber reformation with optical iridectomy, and to control the intraocular pressure, we did a diode cyclophotocoagulation. Post-operatively, she was given intensive steroids, topical steroids, cycloplegics, and anti-glaucoma medications. After 5 months of follow-up, the cornea was clear in this child now. The anterior chamber was deep, the PI was patent, the lens was clear, the disc showed 0.5 cup. However, with 2 intraocular pressure medications also, her intraocular pressure was 26. So a repeat diode CPC was done, and an additional AGM was started. She was advised patching for the other eye and follow-up after 2 months. But she did not turn up for follow-up, and she came a year later. By now, she was 1.5 years old. The corneal haze had increased, the corneal size had increased, the intraocular pressure was uncontrolled, the lens had become cataractous completely, but still the anterior chamber was deep. So now we have a case who had a secondary glaucoma, already undergone 2 diodes cyclophotocoagulations with the total cataract. We were in a dilemma how to proceed with this case. So whether to leave it alone because her fixation was poor, whether to plan surgery as it was a child, the cataract surgery to be done by an anterior or a posterior route, what type of glaucoma surgery, a trabeculectomy, an implant, where to place the tube in the anterior chamber or pars plana, and also these risks of corneal decompensation and choroidal hemorrhage we kept in mind. We proceeded with the pars plana vitrectomy, lensectomy, and Ahmed glaucoma valve in this child. On removing the lens, we could see that the lens, the disc was showing advanced cupping. She was followed up with intensive topical steroids and cycloplegics. And after 6 weeks of surgery, now that the cornea was much clearer than before, the anterior chamber was deep. The tube could be seen in the pars plana. The intraocular pressure was 10 millimeters of mercury without anti-glaucoma medications. The cup, though it was obliterated, the disc was still pale. We were able to refract her and visually rehabilitate her. So this was a 3-month-old child who presented initially, now 1.5 years old, with the congenital fibrovascular pupillary membrane, who did not respond to anterior segment reconstruction, did not respond to 2 diode CPCs, and her intraocular pressure could be brought under control only with an implant surgery. So this congenital fibrovascular pupillary membrane is a condition where a white membrane covers a part or part of the pupil. This is usually unilateral and probably a variant of persistent fetal vasculature. The glaucoma is secondary due to pupillary block and angle closure. UBM, it will give an important information on the diagnosis and classification of this condition. Zhu et al. In this paper, they have classified this condition into 3 types. The U type, where there is no iris-to-iris adhesions, a Y type, where iris-to-iris adhesions have occurred, and type 3, where there is an absent anterior chamber. So this classification of these types will help us to predict how anterior segment reconstruction will control the intraocular pressure. So type 2 and type 3, where there is severe fibrovascular proliferation and iris adhesion, they're usually not amenable only to anterior segment reconstruction. They will probably require anti-glaucoma medications or implant surgery or a cyclophotocoagulation to control the intraocular pressure. So I would like to conclude here, though it is a rare condition, but it has an increased risk of secondary angle closure and visual loss. UBM is helpful in the diagnosis, classification, and predicting the prognosis. Anterior segment reconstruction, it is helpful in all these types. It relieves the pupillary block, forms the anterior chamber, removes the pupillary membrane, and clears the visual axis. These eyes require an aggressive management of intraocular pressure and inflammation and frequent follow-up, because they can easily and very fast progression to type 2 and type 3 can happen. So probably this is a special situation in these children, where an early decision of tube surgery might be required in these small children. Thank you.
Thanks, Parivadin. That was a very, very challenging case and very well managed. So, Teresa, would you like to tell us if you have had any cases like this, your experience in this situation.
Yeah, that's a great question. I'd like to congratulate the presenter for an elegant presentation with great surgical result. I think this is a case that reminds me about the surgical dilemmas that we have when angle surgery is not necessarily a good or reasonable option, because the basic two choices after that are trabs or tubes. I saw a comment in the chat about possibly doing a trab, and my suspicion is maybe in this particular patient, if follow-up is an issue, that doing a trab may be not a good choice in some situations. I usually do trabs if the patients are older than 6 months, but under 6 months, I don't have as good surgical success. In terms of tubes, this is a great option to do a pars plana tube because the patient was already having a lensectomy. Just in other cases where they may not need a pars plana procedure, I of course try to do more anterior tubes instead of pars plana tubes because, of course, in children, if we have to do a pars plana vitrectomy, there's a higher chance of sticky vitreous and RDs. So in general, when I do tubes in kids, I try to do an anterior approach. And then the last thing is I try to do the tube a little more closer to the iris for anterior tubes because as the child grows, sometimes the tube retracts and turns a little more anterior. So those are my thoughts on non-angle based surgery for kids, but excellent presentation.
Yeah, thanks, Teresa. So Dr. Mandal, would you like to comment? I think there are a few patients that you had treated.
Yeah, we have treated patient where lens was clear and there was shallow chamber and the pupil was not formed. We did, with the vitrector, we created pupil, understood the lens is clear, and because pressure was high and because of the Slem's canal was not there, anatomically absent, we did only trabeculectomy with a small air bubble injection into the anterior chamber just to reform the chamber. And the child completed probably about 10 years of follow-up by now and doing well. Although vision is poor because it is unilateral and cornea is clear. To start with, it was having hazy cornea.
Thank you.
Can I make comments, Sirisha?
Yeah, please, Vinay.
I was just wondering, what are the long-term outcomes? Because, we've seen a lot of these kids and the long-term outcomes are really not so good because there's always a recurrence of this fibrovascular membrane, and the cornea actually decompensates over time. So, our experience is not very good because the cornea actually eventually goes from bad to worse, and these children require multiple surgeries, a corneal transplant also. So I was just wondering what your experience has been in the long term.
Yeah, I agree with you, Vinay. So it depends on like what Dr. Mandal said. So it depends on when they present. I have operated a child who was 1 week old when they presented with this kind of an iris Bombay, and you know that it's secondary glaucomas. They can, this pupillary block glaucoma in these kids can progress very fast. In the next 1 month, you will see the corneal diameter from 11 millimeter go to 14 millimeter. So it can be really, really bad. So if they present early, and just the iris now separates from the cornea easily, then just with the pupilloplasty and a clear lens, and of course with aggressive amblyopia treatment, we'll be able to manage. And I have a kid who's again some 6-7 years of age now, but with amblyopia, but on a single medication is maintaining well. On the other hand, what you said, I totally agree that if there is iris which is plastered quite significantly to the cornea, then the cornea, even though you're able to separate it, create a pupil and do all of that, the cornea does decompensate in the future. So it's not easy to manage these kids. And if they have a corneal diameter 15-16 millimeters, I think we have to be very, very clear about whether we really want to do anything intraocularly to try and rehabilitate, because it's going to take multiple interventions and ultimately we don't know whether we'll be able to help. And since this is uniocular, we have to be very, very careful. Yeah, read the comments. Maybe we can take
Just make one quick comment.
Yeah, please.
Yeah, I'm not sure why we named this differently. This is a form of persistent fetal vasculature. And just like, the more common persistent fetal vasculature that forms a retrolenticular membrane, if you don't get the whole thing, it comes back and it's very bad. You have to get the whole thing. So this is full of blood vessels and it's hard to get the whole thing. So this is why it's so difficult. I think if you get it early and you get the whole thing, you can have a much better outcome. But the challenge is those blood vessels are there and you irritate them and you didn't get them all, it grows back very aggressively.
Yeah.
I think we should just consider it persistent fetal vasculature. I'm not sure what it's called, fibrovascular membrane, whatever. I mean, it's a form of persistent fetal vasculature.
Dr. Parivadini, there is a question from Gauri Murthy. Why wasn't a trap considered in conjunction with iridotomy or later in preference to diode?
At that time, ma'am, the cornea was still hazy and we could see that the angles had completely closed. We were not sure whether the trabeculectomy will work. The first sitting, we were not thinking about doing a trabeculectomy because the disc was still okay. We thought we'll form the anterior chamber and see. With relieving the pupillary block and with anti-glaucoma medications, we'll be able to control the pressure. And when the second sitting also, the pressure was still high, we thought we will repeat a diode and see how it works. Later on, we will do an implant surgery. But then she came with total cataract, then we had to do a lensectomy along with the... Dr. Sumita was...
I'll tell you how, because I have done 2 or 3 patients like that, and
Sumita, sorry to interrupt. So I think we'll move on to the next presentation. Sumita, please type.
No issues.
Please type your. Sorry to interrupt, but please type your response on the chat box. We'll move on to the next case. Rashmi can start the presentation, please.
Can you see my...
Yes, please go ahead.
Can you see my slides, Dr. Sirisha?
Yeah, please.
Yeah, good evening, everyone. I thank Team Ipgs, Dr. Shanta, Dr. Sirisha for giving me this opportunity. So this is a 12-year-old baby boy presented to us with bilateral whitish discoloration of eyes since birth, pinkish discoloration on the face, and pigmentation of the trunk. And there was history of seizures, and the baby was under treatment for that. There was no history of consanguineous marriage, and MRI brain revealed focal dilated ventricles along with mild loss of cerebral volume. So on examination, the baby had bilateral facial port vein stain with corneal haze, and ultrasound biomicroscopy revealed corneal edema with deep anterior chamber and clear lens in both eyes. B scan showed attached retina with choroidal thickness of 1 millimeter in both the eyes. So on examination under anesthesia, the horizontal corneal diameter was 12 millimeters in right eye and 11.5 millimeters in the left eye. Intraocular pressures was 18 millimeters mercury in both eye, and there was no view of the fundus in both eyes because of corneal edema. So with this clinical picture, we arrived at the diagnosis of phacomatosis pigmentovascularis. PPV is recognized by simultaneous presence of capillary malformation and pigmentary nevi, and on the face it often covers the ophthalmic division of the trigeminal nerve with pigmentary nevi affecting the body as well. So glaucoma and PPV has a bimodal presentation. One is in the congenital onset and the second is during the teenage years. Treatment in congenital onset glaucoma with PPV is surgical, and similar to primary congenital glaucoma, as angle dysgenesis is the possible mechanism of glaucoma, combined trabeculotomy and trabeculectomy is our preferred surgical technique. However, there's high rate of surgical complications like choroidal detachment and suprachoroidal hemorrhage because of the increased choroidal volume in these eyes, both intra and post-operatively. Hence, care should be taken to reduce IOP preoperatively, perform quick surgery, and avoid hypotony in the postoperative phase. Though CTT is our primary choice due to the angle pathology, but I chose to do an angle-based procedure in this case due to the corneal haze and ab externo 360 degrees illuminated microcatheter assisted trabeculotomy was performed. So this is a short surgical video. After the dissection of the superficial scleral flap, a central radial incision was gradually deepened to identify Schlemm's canal. An indigenously developed illuminated microcatheter was passed circumferentially and the catheter was exteriorized, thus completing 360 degrees trabeculotomy. PPV is a clinical diagnosis with a known somatic genetic mutation association. So a scleral tissue was sent for genetic testing. So the genetic test revealed 2 uncertain significant heterozygous deletions in GNAQ gene, which is associated with Sturge-Weber syndrome, and a single likely pathogenic heterozygous deletion in the RASA1 gene, which causes capillary malformation. Coming back to our patient, post-operatively, both eyes were doing well with clear cornea, well-controlled IOP, and healthy optic disc at the post-op month 4 EUA. So there is a case series, which is a retrospective consecutive case series on 13 eyes of Sturge-Weber and 9 eyes on phacoematosus pigmentovascularis that found that ab externo microcatheter-assisted trabeculotomy significantly reduced IOP in both the groups. However, in Sturge-Weber syndrome, it achieved a higher success rate and sustained midterm efficacy compared to PPVIs. Although our patient showed a good outcome at 4 months, long-term follow-up is necessary to provide deeper insights into the effectiveness of this technique in our PPV patients. So thus to conclude, phacoematosus pigmentovascularis is a rare condition where glaucoma exhibits a bimodal presentation. Systemic evaluation is crucial in both prior as well as during surgical management. Given that angle dysgenesis is the primary pathology, angle-based surgeries do have a role to play. And external 360 degrees trabeculotomy successfully and safely control the intraocular pressure in our child, at least in the early 6 months post-operatively. While PPV is primarily a clinical diagnosis, it has been known to be associated with a somatic genetic mutation. So scleral tissue or the affected skin biopsy needs to be sent for genetic analysis. Thank you.
Yeah, thanks, Rashmi. That was a very crisp and a clear presentation. So any comments from the panelists?
Can I make just a few comments?
Yeah, please.
I'll make them very rapid in a few seconds. To start with, let's say the scleral sample. Now, in the video, you demonstrated taking a sample of the sclera from a remote site. Now, given the probability that the surgery may fail, although it won't fail, hopefully, because it's 4 months follow-up now, but you've weakened an area of the outer coat of the eye and hence risking the probability of the occurring of staphyloma if the intraocular pressure becomes uncontrolled in that place. So, just a suggestion, wouldn't you have considered taking a part of like a corneoscleral block, just in the way as you're doing a combined trab? So after you've done the 360-degree microcatheter, as if you're going to do a trab, and taking that block from underneath the superficial triangular scleral flap, so it would be protected by the flap when it's closed. So that's the first comment or question. Let me quickly thereafter. The next one is considering the high probability of the occurrence of choroidal effusions, as you've mentioned, in glaucomas with episcleral angiomas, why not consider performing a prophylactic inferior sclerotomy at the time of the glaucoma surgery, whatever that glaucoma surgery is going to be? I mean, we're going to induce hypotony, and this hypotony might risk the occurrence of suprachoroidal effusion. So I'm going to prepare an sclerotomy at a distance of 8 to 10 millimeters at the intratemporal limbus. Make sure that it remains open by cauterizing the edge of the sclera, closing the edge of the conjunctiva, so that if choroidal effusions develop, they just drain to the subconjunctival space, just as if I'm making an inferior filtering bleb. The third issue is the aged surgery. That child was just 12 days old. So whatever procedure we choose to do, we're going to open the conjunctiva, and so we're going to induce significant scarring, and we're going to face the problem of a narrow palpebral fissure. So my argument is simply, I wait for these children to the age of 2 to 3 months, that is day 60 to day 90. They don't have much to lose because the condition is already of poor prognosis, and we explain this to the parents because it's a congenital onset of glaucoma. On the contrary, for the surgeon, the palpebral fissure has enlarged a little bit. There may have been a sort of, I hypothesize, a sort of postnatal maturation of the angle of the anterior chamber, which might make the surgery procedure or outcome a little bit more favorable. End of comments. Thank you very much.
Yeah, Rashmi, responses, please.
Thank you for your comments. So the first part is taking the part of this ostium or the deep ostium. So this phacomatous pigmentovascularis is a somatic mutation, and it involves the mutation can be picked up by taking the biopsy from the tissues, which includes the blood vessels. So either we take the biopsy from the post-auricular skin, which has an angioma, or the superficial scleral tissue, which has some of the blood vessel walls included in that. So I feel that taking the biopsy from the deeper ostium, we may not pick up the genetic association in this
we may consider the tenon conjunctiva instead. Just a thought. I'm not sure, but just a thought. But thank you very much. Okay.
Yeah, and the next part is the patient presented at 12 days, but we waited for 1 month and the surgery was performed at 1 month. And because the cornea is cleared and the disc was appearing healthy, I feel in this baby, now we have seen the baby at 8 months now, and the baby is doing well. And we feel that at least till now, the prognosis in these eyes is relatively good as far as I've seen. This is the third baby I have operated 360-degree trabeculotomy in PPV, and all the three children are doing well in the early postoperative phase at least. So that is
that parallels our experience, by the way. In the same, they do behave well with anger surgery. Yes, excellent comment. Thank you. Okay, thank you very much.
Yeah. So Sushmita, do you want to comment on sclerotomy in these eyes?
So thank you for the comment, Dr. Bayami. I've seen that the ones who present congenitally don't really have so much of choroidal effusions as much as those who present later, which is in the second decade usually. Those are the children where and offhand, my thinking is possibly because in the congenital age group, the sclera can stretch. So possibly the choroidal effusion has space to get out that way rather than push the retina in. So at least in the smaller children where we know it's a trabecular meshwork problem, I wonder whether we would need the sclerotomies. But thank you for your comment, Rashmi. I had the same question. And if we need blood vessels, maybe Dr. Arif or a geneticist can answer. Can we just take subtenon's tissue with a lot of blood vessels instead of the ocular coat?
Theoretically, yes.
Yeah.
I mean, but practically, I can't say. I don't have any experience with doing that.
Yeah. So if I can comment, it's not easy because we've got more negative tests than positive tests, and we can't go on taking biopsy. So we have to have a tissue, whether the pigmentation that is involved or the blood vessel. Blood vessel is going to bleed a lot. So typically, I would choose a tissue where there is some amount of pigmentation that you see, especially in these PPV patients. Or if it is Sturge-Weber's that you want to do, then obviously you have to include a part of the tissue which has blood vessels. So it is the abnormal tissue alone can give you a report. Otherwise, I mean, they give you a positive result. Otherwise, often we see them as negative results. So you may ask me, do we need a genetic testing to do this? But there are other reasons why we need to do it, because we have seen studies where whether it is PPV or with Sturge-Weber, some do well, some don't do well. So what we need to understand is the phenotypes are not similar. They have flat vascular malformations, which are these port-vein birthmarks. Some of them have hypertrophic tissue. Some of them have different kinds of manifestations. The phenotype is not at all similar. So I think we are dealing with different problems and different conditions, and maybe 10 years from now, we will be able to answer something. But at the moment, that's the reason why we are actually looking at seeing are there different genetic associations with these. Yeah, totally thank you so much. We'll, if anyone else has any comments, please put it in the chat box. So I think we will have time at the end of the session to discuss as well. We'll move on to the next presentation, please.
Thank you.
Yeah, Pratinya, please go ahead.
Good evening, ma'am. I hope my slides are visible.
Yeah, please.
So today I'll be describing an interesting example of how detailed follow-up and systemic clues can lead to a rare genetic diagnosis. So this is a case of a congenital primary aphakia with PAX2 mutation in a child with papillorenal syndrome. So this case is about a 6-year-old girl who first presented to us at the age of 10 days, and her parents noticed a whitish appearance in both the eyes since birth. She was the firstborn child of a third-degree consanguineous marriage with a history of preeclampsia and gestational diabetes during pregnancy, and she had a low birth weight of 1900 grams at birth. So on examination, as we can see here, both the eyes had silvery white corneal appearance with a poorly defined limbus. And ultrasound B scan, it revealed the absence of lens echoes. And based on these findings, a clinical diagnosis of bilateral congenital aphakia was made. And given the rarity of congenital primary aphakia, we initially suspected FOXC3 gene mutation, which is typically associated with congenital primary aphakia. However, genetic testing, to our surprise, showed no pathogenic variants. This was unexpected and added complexity to the case. The child was followed up regularly, and during the follow-up, it was noted to have a high intraocular pressure in both the eyes with the enlargement of the left eye. Given the risks of phthisis and hypotony with this surgical intervention in congenital primary aphakia, anti-glaucoma medications were prescribed and were augmented as needed. And but during the follow-up, a child developed systemic symptoms like facial puffiness, pedal edema, and anasarca, and she was also hospitalized in the recent past and treated for idiopathic nephrotic syndrome. So this prompted us to suspect a link between the ocular and the systemic findings, and which led to a repeat genetic testing. And on repeat genetic testing, a heterozygous mutation in PAX2 gene with autosomal dominant inheritance was detected, and this was validated by Sanger sequencing. And family testing also was done, which revealed that the father was also positive for PAX2 mutation, although he was asymptomatic. The PAX2 mutation linked the child's ocular findings and the systemic renal pathology. So with the positive PAX2 mutation and the possible association of the papillorenal syndrome, despite normal ultrasound of the kidneys, a kidney biopsy was further performed and it showed focal segmental glomerular sclerosis, which validated the diagnosis of papillorenal syndrome. Congenital primary aphakia is typically linked with FOXC3 mutations. PAX2 mutations are extremely rare with only one prior report. And PAX2 is located on the short arm of chromosome 10, which encodes a transcription factor for the eye, kidney, and the brain development. Its role here demonstrates the overlap of the ocular and the systemic embryogenesis. And papillorenal syndrome, also known as renal coloboma syndrome, is rare with fewer than 200 cases reported. It involves diverse ocular findings, where most commonly optic disc dysplasia is noted. But in this case, congenital primary aphakia with the papillorenal syndrome and morphologically normal kidneys but focal segmental glomerular sclerosis makes this a rare presentation, and it also highlights the variability of the clinical manifestations in the papillorenal syndrome. So I would like to end my presentation with these 4 take-home points from this case. Firstly, congenital primary aphakia is most commonly linked to FOXC3 mutations, but other genetic mutations like PAX2 are also possible. Ultrasound B scan is crucial for diagnosing the congenital aphakia in neonates. Third, negative genetic testing does not rule out the mutation, especially in cases where the systemic manifestations happen, like the systemic clues in our case of the renal problems guided us for the repeat testing and led to proper diagnosis. And finally, multidisciplinary management is very essential in addressing the systemic and the ocular manifestations in these rare syndromes like papillorenal syndrome. Thank you.
Thanks, Pratinya. So comments quickly from Arif and Ria and
yeah, I missed it. What was that variant classified as? What was the pathogenicity? Sorry, you probably said it.
Yeah.
Was
so
it classified as VUS or probably pathogenic? What was the classification?
No, you can
I
in the
forgot.
first setting or in the second report?
second one. First one was negative.
The first one was negative. Yeah. So the variant.
Variant status, it's
Uncertain.
not giving a report. Oh, on the top, uncertain significance.
Yeah.
Okay.
Uncertain.
Well, listen, there's one thing I'm dying to know. You mentioned that the father had the same. Did anyone examine the father, his discs, his optic nerve heads?
Yes.
And
Except he had some posterior subcapsular opacity, but other than that, the optic nerve
his optic nerve head was normal?
was normal. Yeah. We did examine his father, her father.
Okay.
Yeah.
Well, it's interesting, the PAX2 mutation, causes typically the papillorenal syndrome, and the disc appearance is so classic for that. It's really, really characteristic. But you
Yeah.
can have patients who just have the renal, just like the, Usher syndrome, which is retinitis pigmentosa and deafness is commonly caused by USH2A mutations, but USH2A mutations can also cause isolated retinitis pigmentosa without deafness or deafness without retinitis pigmentosa. So PAX2 mutations can result in renal disease without optic nerve findings. Also, I don't know if this has anything to do with the aphakia or not. It's just so hard to prove that. Then why doesn't the father have it? It's hard to make that say that's causative. I think it's probably associated with the renal, but to say that it's causing the aphakia, I don't see evidence for that. As we heard in the other presentation, when you do these analyses, you find these variants in all of these genes that have nothing to do with what you were looking for before, and sometimes they're related to the phenotype you're looking at, and sometimes they're not. So I don't think we have enough evidence. I've never heard of aphakia with PAX2 mutation. You said in the literature search it was negative?
There was one report where the congenital PAX2 mutation was found in congenital primary aphakia.
Really? Okay, I'm not aware of that. Yeah.
This was the report.
I'll say one thing about PAX2 mutation, which is which is relevant for glaucoma. It causes an optic nerve dysgenesis with cupping. It's a very large cup and a lot of cilioretinal vessels. And there's also optic nerve defects also. And some of these patients, if you go to glaucoma clinics, not your glaucoma clinic, but if you go to adult glaucoma clinics and you find patients labeled as low tension glaucoma with idiopathic renal failure, some of those patients are PAX2 mutations and they never had glaucoma. So I think that's the most relevant thing I could say about the PAX2. But regarding this association with aphakia, it's new to me. I think it's very hard to prove. You'd have to demonstrate it in more. And why is the father not have anything? So, yeah, I don't think this is completely solved. It's suggestive and it's very interesting.
Yeah.
But I don't think we have enough evidence at this point.
Yeah. Thank you. So we'll discuss about this case of the meeting. Yeah. So Ria and Gaura, if you have any quick comments about this case, about why it was negative at the first instance and why was it positive at the second instance, because negative test is something that you spoke about. And like what Arif says, is it really causative, or are we missing anything? Quick comment, and then we move on to the next one. Yeah.
Yeah, so probably the reason for the first test to be negative was the phenotype provided was primary congenital aphakia, and since they had looked for OXY3 gene, which is usually reported with the congenital aphakia, so they wouldn't have looked into this PAX2 gene. But when in the second time when you gave the phenotype as a renal failure, they would have looked into all the genes that can cause renal failure. So that's when the PAX2 gene has been picked up. So it's very important that what phenotype we provide to the gene, to the lab, so that they pick up all those genes which are associated with that condition.
Thank you. So anything here?
Yeah, I just have a very quick question. It's a possibility I missed it. when you did the renal biopsy and did the histopath on it, did you also check for gene mutation in it, or the one that you identified in PAX?
No. It was not checked from the renal biopsy. It was from the genetic testing.
Okay. Maybe that could be looked into just to prove pathogenicity in case testing the father is not getting you somewhere.
Yeah. Thanks for the insights. Yeah. So can we move on to the next presentation, please? Manik can share.
Yes.
Yeah.
So good evening, everyone. Thank you, Ipgs, for this opportunity. So I'll be discussing a case of coexisting congenital glaucoma and PPCD in presumed infantile PCG. So an 8-month-old male presented with mother complaining of progressive enlargement of the left eye since past 4 months. They consulted elsewhere and the IOP recorded was 28 millimeters of mercury in the left eye and was started on brinzolamide 1% eye drops. Family history was negative and birth history was uneventful, and there was no history of any trauma to the eye. On clinical evaluation, we can clearly see that the left eye appeared larger than the right eye and there was presence of corneal haze. However, he was fixing and following light in both the eyes, and the intraocular pressure was 10 in the right eye and 24 millimeters of mercury in the left eye, and the left eye optic disc was cupped. On plotting the axial length, we can see that the left eye axial length was falling above the normal growth, above the 2 standard deviations for the age. While we examined the child under anesthesia, we can see that the cornea clarity was grade 2. There was presence of both thalamus and limbal stretching. And on retroillumination, we can see that there was presence of Hab striae. On gonioscopy, there was high iris insertion, and IOP measured at this point of time on EUA on Perkins was 16 millimeters of mercury on single AGN. The horizontal corneal diameter was 12.5, and the axial length was on the higher side. The right eye examination findings were within normal limits. The optic disc in the left eye had 0.6 to 0.7 cup, while the right eye optic disc was normal. We also did UBM, and the right eye UBM showed normal corneas, and the trabecular meshwork was nicely visible. In the left eye, there was presence of Descemet breaks, and the TM was poorly visible. So we made a provisional diagnosis of left eye primary congenital glaucoma and took the child for surgery. Fortunately, we were able to manage 360-degree GAT in this hazy cornea. Post-operatively, the patient was doing well, and we can see that the cornea had cleared up and the intraocular pressure was 10 millimeters of mercury off drugs. Meanwhile, the genetics report came, and surprisingly, the child was carrying a heterozygous autosomal dominant mutation in the GRHL2 gene, which was of uncertain significance. We also did Sanger sequencing in both the parents, and mother was also carrying the same gene, same genetic mutation. So let us go back and reevaluate the examination findings in this case. So on retroillumination picture, we can see that the concentric lines in the periphery were typical of the Hab striae that we see. But in this central area, we can see that there was a straight band-shaped line which was suggestive of classical railroad or snail track pattern that we see in PPCD. Now, carefully looking at the UBM, we can now see that the Descemet break was seen on the right side of the UBM, while the central and the left side of this UBM picture show only Descemet thickening and no break was noted. Evaluation of mother was also done, and the clinical evaluation and the specular microscopy of the mother was normal, and she didn't have any symptoms as well. So on further follow-up, we can see that the child did well post-operatively. At 3 months, the IOP was controlled, and at 6 months and at 1 year, the IOP was controlled. And at this point of time, the axial length had started to stabilize and the child was doing well. So coming to discussion, posterior polymorphous corneal dystrophy is a rare autosomal dominant disorder primarily affecting the corneal endothelium and Descemet membrane. The genes associated regulate the epithelial to mesenchymal transition are OVOL2, ZEB1, and GRHL2, which has been linked to the PPCD4. Most patients remain asymptomatic throughout life. The unilateral disease presentation can be common in children with the other eye being involved later in the life, and these unilateral cases do have amblyopia. The secondary complications include corneal edema, glaucoma, PAS, and Ectopia, and the risk of associated glaucoma is around 2 to 14% according to the literature. The postulated mechanisms in PPCD, glaucoma is abnormal endothelial cell migration over the trabecular meshwork as well as high iris insertion. To our knowledge, this is the first case in literature of PPCD associated with both thalamus and glaucoma presenting in childhood. So to conclude, this rare dual pathology highlights the intricate relationship between genetic mutations and ocular development. The findings suggest a potential novel association between PPCD and congenital glaucoma, proposing that PPCD may represent part of the clinical spectrum of pediatric glaucoma as a developmental disorder rather than only as a secondary glaucoma. So these are my references. Thank you for listening.
Yeah. Thank you, Manik. That was a wonderful presentation and a very interesting case. Arif or any other panelists would like to ask a question?
The parent who was carrying the mutation obviously must have been examined. What was the status? I don't know if you mentioned it.
Yes, sir. So mother was normal. She didn't have any symptoms. The cornea and specular microscopy was normal.
Okay, are we sure this is a pathogenic variant?
So the ACMG classification classified it as uncertain significance, actually.
Yeah. So it's possible that this is not a pathogenic variant. If you see nothing in the parent at all, it's also possible it still is pathogenic. But I've never seen a patient with PPCD present with glaucoma so early. I'm not saying it's impossible, but it could be also that the patient has glaucoma and just happened to have that PPCD, which was not contributing to the glaucoma. Again, you have very interesting, confusing cases here that you're presenting. We would like to, our brains like to put everything together, and we would like to attribute everything to that variant. But, the absence of any finding in the parent who's carrying it, if the parent was carrying, had some finding there, that would be stronger evidence. But if the parent who's carrying that mutation has nothing, even on spectral microscopy, it's still not impossible, but it makes the evidence lower, that it's pathogenic. It's not necessarily pathogenic.
So, but the child did have the corneal findings of PPCD, so we are not sure, we can never be sure, but this PPCD and the GRHL2 mutation might be causing the glaucoma.
Yeah, so we can't be sure, but yes, you have a condition there, and there is glaucoma, and there is an association. So we have seen children with PPCD, and maybe the youngest I have seen is about a year and a half, but we have typically seen children who are older than maybe 5 or 6 years. So I have
that's more typical, but
yeah.
So I think before you can say, it's suggesting it, but there needs to be more evidence, I would say.
Yeah.
Certainly very interesting and suggestive, but not conclusive.
Yeah.
Can I have one?
Why not?
Question?
Yeah.
Sorry to interrupt you.
Yeah.
One rapid question. If you would have diagnosed the PPD before doing the GAT, would you have considered an ab externo procedure rather than an ab interno procedure? Just that question.
Yes, definitely, sir. We would have considered, but we were seeing the angle so nicely, so we did GAT and we went ahead with GAT.
Thank you. Thank you very much.
Yeah. Anyone has any question, or we move on to the next presentation? Yeah, Vinay, please go ahead.
Are my slides visible?
Not yet.
Oh.
So while Vinay is figuring out the presentation, so I had one question. So if it is PPCD induced and related to the angle that is abnormal because of the endothelial proliferation, maybe an angle procedure may fail with time. And if we had known this, then maybe an external trabeculectomy would have a better option.
Yes, ma'am. If we had known before, then we would have not ahead with the external combined rapid trap, definitely.
It's just that on reviewing, all the reports of the secondary glaucoma were in much older people. So I'm not sure whether this didn't have an element of trabecular dysgenesis as well in the larger picture of dysgenesis. I'm not sure. Like Dr. Arif said, the only thing is it was autosomal dominant. The mother had it, and so we really don't know.
Yeah, thank you. So yeah,
Can
Vinay,
I go ahead?
we can see the slides. Please go ahead.
Okay, so I'm presenting in place of Arnav. So this is an unusual presentation of a juvenile open-angle glaucoma who was a 15-year-old male, and he had presented with a decrease in vision, which he started having after his Covishield vaccine. So this happened 2 weeks later after the vaccination, where he developed intense headaches and colored halos. His intraocular pressure was noted to be more than 60 millimeters of mercury at that time, and he was then started on medical treatment elsewhere. He only came to us in May when his intraocular pressure was high and his vision was extremely low. He had some retrolental cells, but otherwise his anterior segment was absolutely normal. And apart from a glaucomatous optic neuropathy, his fundus was also more or less normal. Because he had a mild flare and some retrolental cells, so we diagnosed him as a uveitis with a secondary glaucoma. So as you can see, there's anterior segment is normal. There is a mild high insertion of his iris in both the eyes, and an optos revealed a cupping which was almost near total. But beyond that, the vessels were absolutely normal. There were no sheathing of the vessels. There was no evidence of active vasculitis, but there were a few dot blot hemorrhages all over 360 degrees in both of his eyes. So we went ahead and did a fluorescein angiography, and we found this unusual fern-like pattern of leak in both of his eyes, which is so characteristic of a Behçet's disease. But apart from a mild retrodental cells, as I said, there was no other evidence of uveitis. His HLA-B5 and B51, which are most specific of Behçet's, were negative, but he had a B52 positive test, which is not specific for Behçet's. So we started him on oral steroids. We thought it was a Behçet's disease, and he underwent a trabeculectomy in both the eyes for his control of intraocular pressure. However, 1 month later, there was resolution of the entire leakage, while there was some amount of peripheral leaks that were still present. He continued on prednisolone for a long period of time, as our uveitis colleagues wanted him to be on. And the resolution of the leaks continued. There were good functional blebs. His intraocular pressure was well controlled, but because of the steroids, he had developed posterior subcapsular cataract, for which he was planned for cataract surgery. So as you can see here, there was a dramatic resolution of his leaks in both the eyes. And on repeat evaluation after 1 year, there were no leaks, but and I mean, it was very surprising because there was no evidence of any pan-uveitis. There was no evidence of sheathing, which is so characteristic of Behçet's. And despite stopping his oral steroids, the disease is completely resolved. So we did a whole exome sequencing, and we found a heterozygous mutation, which is arginine 368 histidine, which is pathogenic. And based on this, we probably thought that it was not Behçet's, because we didn't get the HLA antigens positive for Behçet's, and we didn't find any other systemic features of Behçet's. There was no evidence of ulcers or any other things. And also the fact that the sheathing and the vasculitis was mainly venular, again went against a characteristic Behçet's. So we went forward with looking at literature, and we found that this fern-like fluorescein angiographic pattern could also be seen in retinal vascular occlusions, apart from Behçet's and other kinds of intermediate uveitis. So probably it was a high intraocular pressure induced vascular occlusion that this child had, which could have been induced by the angle dysgenesis which led to a juvenile open-angle glaucoma, and that these pinpoint hemorrhages marked the vascular occlusion that he had. So although it's extremely rare to have bilateral retinal vascular occlusions with juvenile open-angle glaucoma, but we have seen some unilateral cases with very high intraocular pressure. So we do believe that probably this glaucoma was unlikely to be a secondary uveitis, although we cannot rule it out completely. But the patient had developed advanced glaucomatous optic nerve damage, which we attribute in this case to a primary juvenile open-angle glaucoma. And of course, this fern-like leakage, to our knowledge, we have never seen. I mean, I've seen hundreds of cases of juvenile open-angle glaucoma, but I have not seen a bilateral vascular retinal occlusions leading to a fern-like leakage in this. So this was something which was interesting, and we wanted to report it. So thanks.
Yeah, fantastic, and a very, very rare and a very dramatic presentation, Vinay. So Dr. Ramakrishnan, Dr. Mandal, Manju, any of you have any comments or questions to ask?
No comments. Very rare situation. I have never seen such a case.
No, I was just wondering whether the inflammatory part of it could be related to COVID. You said it was 2 weeks after COVID infection.
Yeah, absolutely, madam. That again is a possibility. I mean, we could not have ruled that out. I mean, I do not know whether COVID vaccination has also been reported to cause such kind of a vascular leakage, but yes, that is a possibility. But then again, we just try to correlate everything. So that is why we put this whole thing together, that it was probably a juvenile open-angle glaucoma leading to high pressures, leading to a vascular occlusion. But as I said, again, I mean, an inflammatory component cannot be ruled out. Yeah.
Thank you.
Yeah. And Teresa, Nader, and
just one small comment. I would add my astonishment to an acute event producing a rapid rise of intraocular pressure over a chronic course. This is most probably the cause, and that's why I agree that an inflammatory component could not be ruled out. I just want to highlight one point to the that the steroids after doing a filtering surgery are protective to the surgery and actually contributing to lower IOP rather than raising the IOP, because sometimes the issue of post-filtering surgery elevation of IOP secondary to steroid use is sometimes assumed. I mean, people don't get the point that after doing filtering surgery, application of steroids delays the healing of the filter and therefore promotes lowering of the intraocular pressure, not elevation of the intraocular pressure. So this issue just to highlight, because your patient had to continue on steroids for some time after doing the trab. This may have enhanced the success of the trab additionally because of the prolonged use of steroids and delayed healing. Just a comment. Thank you very much. It's an excellent and very, very rare presentation. I've never seen this scenario before, actually. Thank you very much.
Yeah.
Yeah, and I also have not seen this scenario before, so thanks for sharing. It also raises the classic question of the chicken and egg, which came first. Like you said, it was a juvenile open-angle glaucoma, high pressure causing the vascular issues, or perhaps even the other way around. I was wondering if there was some vasculitis with some maybe trabeculitis mechanism that could have caused the high pressure. Maybe just the patient was symptomatic from the vasculitis leading to a earlier diagnosis of the glaucoma. But either way, whichever came first, is a very interesting case. So thank you for sharing.
Thank you.
Thank you. Yeah. I think we move on. Megan, it's all yours. Please go ahead and share your screen.
Thank you. I would like to thank IPGS for giving me the opportunity to share our case series today. Can you see my screen? Can you all see my screen?
Yes.
Yeah.
Perfect. So I'll be talking about CYP1B1 cytopathy and how it can lead to phenotypic variability. So typically we know CYP1B1 is the most common genetic mutation that causes primary congenital glaucoma. However, it can also cause a particular phenotype that has been defined as CYP1B1 cytopathy. Just to give a background, it was initially described in 2011, and the characteristics were diffuse avascular corneal opacity, which does not resolve with IOP control, corneal diameter typically less than 12 millimeter, which goes against primary congenital glaucoma. And what was characteristic was the histopathology, where it showed central absence of the Bowman layer, sometimes desmin membrane, and the endothelium with no HAP striae. So we identified 3 cases which had similar histopathological findings and clinical features. The first one was a 2-month-old boy who was referred to our Center for Evaluation of Congenital Corneal Opacity and Glaucoma. The glaucoma was managed elsewhere. It presented at birth, and at 4 weeks of life, the child underwent bilateral trabeculotomies. However, the corneal opacity persisted despite having adequately controlled intraocular pressure. Pertinent medical history on examining the child, he had umbilical hernia, inguinal hernia, and a hypospadias, raising the concern for Axenfeld-Rieger syndrome. On examination in the OR, as you can see in the right eye, the corneal diameter was about 10 millimeter, the axial length was 19.5 millimeter, and in the left eye, similarly, 9.5 and 19.5 millimeter was the axial length, and the intraocular pressure was soft to moderate to palpation. The child underwent penetrating keratoplasty in both the eyes and did very well. Once we've done the transplant, we were able to take a look at the optic nerve, and it did show a cup-to-disc ratio of 0.2 in both the eyes. However, at the 1-year post-op, there was some increase in the axial length, so we ended up doing a cyclodiode laser to sort of control the pressure a little bit. But what's interesting was we were able to send the corneal button that we had taken during the time of transplant for histopathology. And as you can see, this is the right eye. And if I zoom in this area, the Bowman's layer was much, much more thickened as opposed to what you would expect. For comparison, this is a normal 9-week infant's corneal histopathology. And the Bowman's membrane was not only thickened, it has a lot of myxoid stroma and abnormal cellularity. Normally, it should be acellular. Similarly, in the left eye, the Bowman's membrane was thickened. However, we were able to examine the whole section of the cornea that was taken out, and it did show an intact desmin membrane. So it wasn't a desmin membrane rupture causing the corneal edema, but a different kind of mechanism causing disruption in the architecture in the cornea. We did do genetic testing for this patient, which did show compound heterozygosity for 2 CYP1B1 variants, which are pathogenic, and these variants have been reported classically to cause primary congenital glaucoma. Going on to the second case, was a 2-year-old boy who presented with bilateral congenital glaucoma and diffuse dense corneal clouding. Again, was referred to us for consideration of a penetrating keratoplasty. He was diagnosed with glaucoma at 10 days of life and underwent multiple cyclodiode lasers and subsequently a tube shunt in both the eyes at another location. The IOP was effectively controlled. However, the corneal opacity persisted. As you can see, however, in this case, the corneal diameters were raised 13.5 millimeter in the right eye and 13 millimeters in the left eye, and so were the axial lengths, and the intraocular pressure was high. What was interesting was, as you can see, there's a diffuse corneal opacity, limbus to limbus in both the eyes. When we did a UBM, the iris stump, as you can see here, the iris was missing, and there was a very small stump that was present there. However, there was no iridolenticular adhesion to the cornea. So this patient also underwent a penetrating keratoplasty to visually rehabilitate the patient, and the fundus exam revealed a cup-to-disc ratio of 0.4 in the right eye and 0.1 in the left eye. And histopathology also showed similar findings, where peripherally there was thickening of the Bowman membrane, and centrally the Bowman membrane was absent in this section, as you can see, and right eye also had similar findings. Genetic testing in this patient as well showed homozygosity of a CYP1B1 missense variant, which has been shown to cause primary congenital glaucoma. The third case was a 3-year-old girl who presented with bilateral congenital glaucoma and congenital corneal opacity, underwent trabeculectomies followed by tube shunt with satisfactory IOP control. And the left eye actually had cleared up after doing the shunt surgery. However, the right eye persisted to have a central corneal opacity with some peripheral clearing, as you can see in this picture. So before presenting to us, she actually underwent a selective endothelial removal to see if the corneal opacity in the center would decrease. At presentation, the corneal diameter was 12 millimeter in the right eye and 12.25 millimeter in the left eye, with slightly raised axial length for age, 23.31 millimeter in the right eye and 25 millimeter in the left eye. So because we had this clear zone inferiorly, we ended up doing an optical iridectomy. This case as well had similar CYP1B1 mutations that have been described in primary congenital glaucoma. It was a compound heterozygous mutation, but we weren't able to define if it was pathogenic or not because parents declined testing. So you can have phenotypic variability in CYP1B1, as we see in these three cases. The first one had a characteristic histopathology and the same findings as I described earlier. The second one presented more like an aniridia finding, but the histopathology is what gave the diagnosis. And the third one was a unilateral presentation with iridocorneal adhesions. So CYP1B1 can cause multiple anterior segment anomalies. And it is a spectrum. Rather than thinking about it as one thing, we should think about it more as a spectrum and look into all of these findings. To conclude, CYP1B1 cytopathy is an anterior segment developmental anomaly with characteristic histopathological findings. You should suspect them in any case where you've controlled the IOP and the corneal opacity is still persisting. Thank you.
Fantastic presentation, Meghal, and very, very interesting and difficult case series. And it's not uncommon for us to see that. And it's one of the most difficult variant and a very severe variant of congenital glaucoma that we deal with. Arif, would you like to comment?
Yes, I would. So, this is a very interesting topic. The same CYP1B1 mutation in one patient can cause primary congenital glaucoma, another patient juvenile glaucoma, and another one this horrible phenotype where they have this intrinsic corneal opacity, and which is a sign of a glaucoma very difficult to control. Many of the cases that I've seen that are neonatal onset that have this keratopathy, they have partial aniridia, and they have a rim of ectropion uvei around the iris. Sometimes you don't see it that well, but there's some ectropion uvei there. And I'm wondering if these cases, one of them you mentioned had aniridia. Sometimes it's just partial aniridia. It's so, right. You might think the pupil is just a little bit dilated, but actually no, there's just lack of iris. But one thing that's almost always there is this rim of ectropion uvei, which can be very slight. I wonder if those patients had that.
So,
or you're not sure?
I'm not sure. Not the first one. The first one did not. The third one, yes.
So the first one just had the CYP1B1 keratopathy without any lack of iris or ectropion uvei.
Yes, and okay. I'm glad you mentioned that, because in the third case where we did the optical iridectomy, we actually sent that iris sample for histopathology as well. I did not mention it, and it did show some fibrosis and metaplasia there, which kind of goes with having an ectropion uvei. But that was the only case we had iris sample from, so we couldn't conclude if it's there in all of them.
I think the major point is that this keratopathy is intrinsic to the cornea. And I think the first case that you showed, the corneal diameter wasn't even enlarged, yes, which was more evidence that the haze was not from increased intraocular pressure. So it's important for those of us who take care of congenital glaucoma to realize that there are these cases out there and that not all corneal haze is from increased IOP. And the second thing to know is that when you see that, it's just a marker that it's a very difficult case to deal with. The angle maldevelopment is usually quite severe. Thank you very much.
Yeah. Sushmita?
Yeah, so we agree with Dr. Arif's report was what made us look at it. And interestingly, we called it neonatal onset CEU to differentiate it from primary congenital glaucoma, because if you have partial aniridia and a bit of ectropion, it's not PCG, because by definition, it's another entity. But at least in our Northwestern ethnicity, we found that one variant, arginine 392 histidine, which was common in about 85% of all the babies that we saw. And I'm so glad Dr. Arif made that comment, because we've also noticed that it's only the ones which have large corneas and Harb's striae with the corneal haze are the ones which really clear after surgery. But if you have a smaller eye and a smaller cornea and this horrible white thing in the center, you know that that's not going to clear. And for paucity of PK eyes that we have in our institution, we do a lot of iridectomies too. Thank you. Thank you for bringing this in.
I have one question, Meghal. Were the corneal buttons also subjected to analysis of the CYP1B1?
No.
Okay.
I also had a question for the presenter. This is a wonderful case and beautiful reminder of some genetic causes of persistent corneal opacity. But in our practice, most of my cornea colleagues don't do transplants in children under 5 years of age because of the poor prognosis. But you've had such beautiful results in these patients. What's your secret? And do these patients do better with transplants than other patients?
I'm not a pediatric cornea surgeon, but it's my mentor, Professor Ken Neschel, and he typically does corneal transplants as young as 6 to 8 weeks of age, for some of these congenital corneal opacities.
That's wonderful. Congratulations.
Yeah, just a comment. I would say this condition is an enigma, and there's a lot more that we need to understand. And maybe in the coming years, we will understand a bit more on this condition. But the transplants, while they may do okay in the beginning, these eyes do fail with time, and they're very difficult to handle. So in fact, we do prefer to do an optical iridectomy if there is a possibility where an eccentric portion of the cornea is clear. So they're not easy to handle. Yeah, so we move on. Let's have the next presentation, please.
Hi, good evening, everyone.
Yeah, please.
Yeah. So today I'll be discussing a case of infantile onset primary congenital glaucoma with double variants of CYP1B1 and LTBP2 mutations. So a 6-month-old girl child presented to a clinic when parents noticed whitish discoloration and enlargement of both eyes for 1 month. There was no other significant history, and the birth history was uneventful. Under torchlight examination, she had ophthalmos in both eyes, and IOP on eye care tonometry was 28.7 and 20.5 mmHg in right and left eye respectively. She had corneal haze in both the eyes, with right eye having grade 2 to 3 and left eye having grade 1 corneal haze. And her axil length were more high for her age, and ultrasonography showed both the optic nerve head cupping. So we made a diagnosis of both the infantile onset primary congenital glaucoma, and she was started on brinzolamide 1% drops in both the eyes. So on examination anesthesia, we could see that right eye, both the eyes were having ophthalmos, with right eye having cornea haze of grade 2 to 3 and left eye having grade 1. And angles were all having higher insertion with dystagnatic angles. IOP was 26 and 24 on brinzolamide eye drops, with HCD of 13.5 and 12.5, which is central corneal thickness of 560 and 590, and CDR of 0.8 and 0.6 in right and left eye respectively. Axil length were high for her age, so we made a diagnosis of both the infantile onset primary congenital glaucoma, and she underwent both the goniotomy on 28th of March 2022. After 1 month, her IOP came down to 16 and 14 of AGFs, and her cornea had also become cleared, and axil length had also decreased. Meanwhile, her genetic report of blood came back. Her CS showed CYP1B1 mutation, which was a compound heterozygous mutation with an autosomal recessive inheritance. To our surprise, she also had a mutation in LTBP2 gene, which was also heterozygous autosomal recessive mutation. Since it was a heterozygous autosomal recessive mutation, we advised for tangles of the parents, where we could see that CYP1B1 mutation was present in one variant. One variant was present in the father, but the father did not carry the other variant. But to our surprise, even the unaffected father also had the same variant that was present in the child. And samples of the mother showed that the other variant, which was not present in father, was mutated in the mother, but the variant that was mutated in the father was not mutated in the mother. And LTP2 variant was not mutated in the mother. So in a nutshell, the child had CYP1B1 heterozygous mutation, where one variant came from the father and the other variant came from the mother. But when we consider this LTP2 mutation, the affected child had LTP2 mutation of this variant, but the unaffected child father also had the same variant, and the unaffected mother did not have it. So maybe this unaffected this LTP2 mutation in this child maybe is a chance finding, and maybe is an SNP in our population. To complete my case, after around 1 year, till around 1 year, her IOP was controlled off agents. But after 1 year, her IOP started rising in the right eye, where agents were added. But after 2 years, her IOP and excellence started rising in the right eye, for which she had to undergo right combined rabbit trap. Left eye was stable off agents. So the take-home message is that combined mutation of LTPP2 and CYP1B1 in PCG is unreported to our knowledge. LTP2 mutation is usually present with megalocornea, spherophakia, and secondary glaucoma. This patient has a typical PCG clinical picture. Since unaffected father and affected child has same LTP2 mutation, this LTP2 variant maybe is a chance finding and maybe is an SNP in our population. Thank you all for listening, and thank you Ipgs for the opportunity. Thank you.
Fantastic. Thank you so much for presenting again an interesting case. So yes, Dr. Arif.
Yeah, I think that this is just simply a carrier state. We see this all the time that, people are heterozygous. The phenotype doesn't match what you would expect for LTP2. So I think it's just a chance finding. But it brings up a very interesting point. And I don't know if Ria is still on this meeting. Is Ria still here?
Yes.
Okay, because I want to ask you what you do about this. You did segregation analysis, and thankfully, you found one parent was carrying the one mutation and the other parent is carrying the other mutation. But sometimes you do segregation analysis and you find out that one of the parents isn't really one of the parents. And this happens. And my question is, when you go and do segregation analysis like you're doing, are you informing the family beforehand that there's a possibility that you might uncover non-paternity, and whether or not that should be disclosed? Because, this is a very sensitive and it's a very important topic, and it's a reason why people shouldn't do genetic testing casually, because you can open up a whole can of worms about things. So I wanted to ask Ria about that.
Yes, 100%. It's part of the pre-test counseling session. And so that's something we speak about, that this is the kind of, so looking at genes, this is what it means to look at genes, and this is the kind of information that might come out of it. And believe it or not, we've had cases where it's a family counseling session, and somehow one of the partners has found an opportunity to get us aside on the side and just said that, what, this is what my history is, and there might be something unwanted that comes in the report, or something that's not discernible, and then one has to tackle with all of that. But it should be mentioned what genetic testing report might imply.
Have you ever encountered that in segregation analysis when you determine that one of the parents is not really one of the parents? Have you run into that, or?
No.
Okay,
no.
good.
Yeah, so we've had a patient like that. They're twins for a very precious pregnancy, and autosomal dominant axonal rigor is what was diagnosed. The child had typical phenotype, was operated, but the other twin did not have, and both the parents did not have, and this was kind of not very comfortable. And then later on, and when we kept asking them, the mother's sister she came and revealed that actually there was a donor ovum, and that was what was done when the mother had an in vitro fertilization. So it's not easy, but I think what you said is a very, very important point. It's not about picking up something, but then how do you reveal, and then where all it can lead to. So this is very important. Thanks for bringing it up.
Thank you.
I have one point I think Arif has raised regarding is it actually worthwhile digging into all of this when the social ramifications could be much more than the academic or for that matter the diagnostic or treatment options. So it doesn't change.
That's
much.
right.
Yeah.
That's right. This is something that has to be considered. You're right. And this is the importance of genetic counseling also. So, this is a big can of worms you can open up when you start to do segregation analysis. Obviously, when you're just testing the child, that's different. But then when you start to do segregation analysis of the parents, in the United States, I think comes up about 10% of the time. I don't know what statistics in other countries where non-paternity is determined when you go off and do segregation analysis. So yeah, these are important points. I don't have a straightforward answer. You have to have a feeling with the family you're dealing with, the culture you're dealing with, and how much information you want.
Interesting points. Yeah, so I think we can move on to the next presentation so that we don't delay the ones waiting. Indu, please go ahead.
Good evening, everyone. Are my slides audible and am I visible?
Yeah. You are audible and slides are visible. Please go ahead.
So today I'll be presenting an interesting case on ASPH-related ectopia lentis. Consent was taken from the patient and parents to share the full facial photographs. We have a 15-year-old female who came with complaints of both eyes blurring of vision for distance and ear, even with use of glasses since 1 year. She was born to parents with history of second-degree consanguineous marriage. Both eyes, she has unaided visual acuity of contact fingers close to face, improving to 20/100 and 20/80 with very high myopic refractive error. Intraocular pressure with Goldman ablation tonometry was normal in both eyes. Slit lamp photograph of left eye shows scleral thinning supranasally with the staphylomas and spontaneous filtering bleb and peripheral anterior synechia from 2 to 7 o'clock in the periphery. And she has a posteriorly partially subluxated crystalline lens. The slit lamp photograph of the right eye on the bottom shows iris bombay with nasal scleral thinning. And you can see subluxated crystalline lens anteriorly, which is more clearly seen in anterior segment OCT, where the subluxated crystalline lens was almost touching the corneal endothelium. So fundus photography of both eyes shows a healthy tilted medium-sized disc with 0.6 cup disc ratio. She was diagnosed to have both eyes microspirophakia with right eye anteriorly subluxated crystalline lens and left eye partially subluxated crystalline lens posteriorly. She was noted to have long and slender fingers with Marfanoid habitus. So the patient was suspected to have either Marfan syndrome or homocystinuria. So she was investigated for ectopia lentis panel, where 2D echocardiography revealed a atrial septal defect with left to right shunt and interatrial septal aneurysm, and homocysteine levels were grossly elevated. She was referred to physician and appropriately treated with these two conditions. And she was also advised right eye pass panel lensectomy and vitrectomy under general anesthesia. She has a characteristic facial appearance with a long face, high nasal bridge with a beak nose, deviated nasal septum, retracted chin, malar flattening and low set ears. She also has telecanthus and malocclusion of the teeth. Post-pars panel lensectomy and vitrectomy, a slit lamp photograph in the right eye shows a surgical aphakia with inferior patent surgical PI, and you can see that the nasal scleral thinning has become more profound when compared to first visit. And you also see the inferotemporal scleral thinning. The second picture shows huge supranasal staphylomas and superotemporal scleral thinning corresponding to the sites where scleral ports were made for vitrectomy. Slit lamp photography of the left eye shows supranasal staphylomas with spontaneous filtering bleb and nasal thinning, which is stable and same as first visit. At this point, she was lost to follow-up for 1.5 years, and she came after 1.5 years, where she was started on 4 anti-glaucoma medications in the right eye and 2 anti-glaucoma medications in the left eye elsewhere for raised IOP. At this visit, she has early disc damage in the right eye with corresponding visual field defect, and the left eye has advanced disc damage with inferior notch and superior thinning, which shows a corresponding visual field defect of superior arcade scotoma and inferior paracentral scotoma, which is repeatable on 10-2. And she also has dislocated crystalline lens into the vitreous cavity at this visit. And she was advised for left eye pars plana lensectomy and vitrectomy under general anesthesia with clear corneal incisions instead of scleral ports. Due to her typical facial appearance with ectopia, lentis, and spontaneous filtering blebs, we made a clinical diagnosis of Trebolsi syndrome and advised genetic testing by whole exome sequencing, which revealed a autosomal recessive homozygous mutation in the exon 24 of the ASPA gene, which was likely pathogenic mutation by ASMG classification. This confirmed our clinical diagnosis of Trebolsi syndrome. The mutation which we saw was a stop gain mutation, which causes loss of protein function through protein truncation. So whenever we see such patients with typical clinical appearance of Trebolsi syndrome, early lensectomy should be done, as scleral thinning is most commonly seen or starts at the site or towards the side of subluxation, which is mostly superiorly or superinasally. And it is important to make clear corneal incisions for lensectomy instead of scleral boats, as it aggravates the scleral thinning and cephaloma as seen in this case. To summarize, ASPH-related ectopia lentis is a rare entity with typical features of facial dysmorphism, lens dislocation, anterior segment abnormalities, and spontaneous filtering blebs. It is inherited in an autosomal recessive pattern. It can present either with ectopia lentis or glaucoma or hypotony. Cardiac evaluation is necessary to prevent morbidity and mortality, and it should be done yearly, as they can develop cardiac problem at any point in life. Genetic analysis can help us in confirming the clinical diagnosis and better understanding of the disease. Any surgical intervention involving sclera should be avoided, as it may aggravate the scleral thinning and cause cephaloma. Early lensectomy by corneal incision will avoid the scleral thinning and cephaloma formation and filtering blebs. Thank you for patient listening and for the opportunity.
Thank you, Indu. That was an interesting and a difficult case. Yes, Dr. Arif.
Yes, I mean, I'm so happy to see these cases being diagnosed more and more. So many cases from India, so many cases from all over the world now, because originally they were not being diagnosed. They were just being called Marfan syndrome. But now we know, because of the scleral thinning that they have and the distinct facial features, it's really just a separate, very recognizable clinical entity, and we have much more awareness of it now. In the original reports of this, which was in Lebanese Druze patients, there was no association with cardiac problems. But now, as more patients have been reported from all over the world, it does seem that a certain percentage of these patients do have cardiac issues. So not only are we worried about this scleral thinning, and we have to be careful about making incisions in the sclera, which is why it's so important to pick this up, because although some of them present with the scleral thinning and spontaneous blebs, some of them present with the ectopia lentis, and if you go into the sclera and you try to do something, you really throw things off. You really cause a big problem, which is why this has to be recognized by ophthalmologists. But in addition to these ocular things, we have to also refer these patients for cardiac evaluation. And the key really is the nose and the crowded teeth and the chin. Those are the characteristic facial features. But anyone who comes in with ectopia lentis, we should be considering this syndrome. It should be in part of our differential diagnosis, because we don't want to make scleral incisions and lead to those horrible staphylomas that become very difficult to deal with once they happen. Thank you for presenting it.
Thank you. So any other quick comment?
I was just wondering about the raised homocysteine levels. I mean, are they associated with Trebolsi syndrome? Or do you think
it's completely unrelated?
Yeah.
So that one of the reasons why we thought we should present this case is that so it is easy to get carried away. So being a vegetarian, if your B12 levels are low and your homocysteine is elevated, it could be an incidental finding, or possibly the person has two different pathologies. So we don't stop it there. I think once we know that the phenotype is very typical, one of the reasons why we want to present it is because Dr. Arif will remember when many years ago, one such case, I presented it as Marfan's. So it's not easy unless we know that such a condition exists and that these people can have these kind of presentations. And with time, especially the syndromic conditions, don't present with features similar to what we have presented when they are very young. So they do develop with time. So it's very easy to lose or miss an opportunity to pick it up when they're younger. So yes, they could be incidental, Vinay.
Yeah.
Yeah.
I have one final question, please.
Yes, please.
Would you consider supporting these staphylomas with a scleral patch graft? And if you would consider, how would you fix the scleral patch graft? Would you use tissue glue or sutures given the sclera is already compromised? That's a real intriguing issue.
Yeah, I have repaired, I think, 3 patients with this condition. They're very difficult. The sclera just tears if you have to touch. What you asked is an important question. So if the defect is, let's say, in 1 clock hour, there was a patient for whom I had to use a scleral patch graft with almost about 8 or 9 millimeters, because beyond the 8 or 9 millimeters was the area of the sclera, which was reasonable for you to
fix the graft on it. Okay.
Yeah, so I had to give a tectonic support using the glue with air bubble in the anterior chamber, and so that at least it allows it to stick. And then use sutures to the episcleral tissue and did not dare to go and touch the sclera. Very, very difficult, because I'm talking about a boy who presented with hypotony maculopathy with unrecordable intraocular pressures bilaterally. So you have to treat it, but then that's why the best thing is to prevent it. Don't even touch these eyes. The sclera is very precious in them, and then we should not let this complication happen.
Never a filtering surgery if the IOP is elevated. Never.
No.
Thank you very much.
It's like the primary congenital aphakia. You don't want to go intraocular in those. You don't want to go through the sclera in these. It's analogous to that.
Okay.
Yeah.
Thank you. Thank you very much.
So let's have the next presentation, please. So the next presentation, we are done with the cases. It will be a video presented by Dr. Alev. Please go ahead and share your screen and present the video, please.
Dear moderators and colleagues, I'll present trabecular staining with the blue donut technique in GUT for juvenile glaucoma. GUT provided excellent outcomes in juvenile glaucoma. GUT can be challenging in patients with little to no trabecular meshwork pigmentation, especially in pediatric and juvenile glaucoma. Trabecular meshwork can be nicely delineated with trypan blue. Long-term effects of trypan blue on a clear crystalline lens are uncertain. The blue donut technique, which is defined by abuse, allows staining of the trabecular meshwork without inadvertent staining of the lens. Our case is a 30-year-old male with juvenile glaucoma. His IOP in the right eye was 38 millimeter mercury with full medication. On OCT, there was advanced loss on gonio, no trabecular meshwork pigmentation. We decided to do GUT procedure with blue donut technique. Firstly, stir tip is cauterized. After port side incision, myostat is injected into the anterior chamber for meiosis. And 3% sodium hyaluronate viscoelastic fluid is filled into center of the anterior chamber, clear crystalline lens. After the eye is pressurized, dilated trypan blue is injected nasally, blue donut shape is formed. After waiting 30 seconds, trypan blue is aspirated. Anterior chamber is filled again with 3% sodium hyaluronate. Blunted tip 6O proline is inserted anterior chamber. Patient's head and microscopy is tilted for angle surgery. Nasal anterior to blue hole is performed and 6O proline is easily inserted into the Schlemm canal and advanced circumferentially. Tip of or prolonged from opposite side is folded. .360-degree gut is successfully completed. 360-degree angle hemorrhage is observed and anterior chamber washing is done. After irrigation aspiration, wound closure is provided. Air is injected into the anterior chamber for hemorrhagic tamponade, and the operation is finalized. In the last exam, patient's IOP was under control and the crystalline lens was clear. Thank you for your attention.
Wonderful case and very well performed surgery. Thank you. Thank you so much for sharing and joining us from so far. Yeah, so do any of the panelists have a question?
Yes, just an interesting question. The trypan blue is known to stain the anterior lens capsule. So what was the fate of the anterior lens capsule during the procedure, and how long did it take to clear if it was stained during the procedure?
30 seconds. Actually, 30 seconds, we wait for trabecular staining. It is enough, 30 seconds, actually.
What about the anterior lens capsule, not the trabeculum? The anterior lens capsule, we already stained the anterior lens capsule with trypan blue before doing a capsular access. So we've injected trypan blue into the anterior chamber. What happens if the trypan blue just accidentally touches the anterior lens capsule and it gets stained? So how long does it take after the surgery to clear?
Actually, the blue donut technique is for this reason. Because here, firstly, we inject hyaluronate onto the lens to prevent these staining, to prevent these trypan blue touch with the lens. These techniques prevent this. This is why we use this technique, because this is younger patients, and these techniques prevent these. Blue donuts means only in the periphery of the lens, not lens is staining.
Not the anterior lens capsule.
Yes,
okay,
yes.
Thank you very much.
I have a small comment. I noticed that at the end of the procedure, when irrigation aspiration was occurring, only half of the conjunctiva was getting blanched, most probably in the nasal area. So was it really necessary to do a 360-degree cut? Would 180 be sufficient?
Actually, our gut procedure was successful 360 degree, but it is not always, you cannot see the in 360 degree blanching. You can see blanching in some of the part of the 360 degree, but we see that there is 360 degree hemorrhage from the angle.
Thank you.
And also, you cannot predict which area will actually show an outflow. So you cannot decide which 180 degrees you want to treat, because it may not be the area which actually responds ultimately. So it's always good to do a 360 degrees, and we've shown that the 360 degrees actually is much better off than doing just 180 degrees. Yeah.
Surely.
I thought there was some recent evidence which showed that 180 degrees was sufficient, since most of the collector channels are in the nasal area.
Yes. Actually, there are studies, other studies think that there is some GATT procedures would be more effective in the temporal sites, because they think that yes, there is intranasal drainage, there is, but they think that if there is a drainage, its sites are more effective in drainage area. So you should, if you make a surgery, hemigut surgery, you should do it to the temporal side due to this reason. But as Professor Vinay Gupta told us, you cannot never be sure about it. So it is logical to treat it 360 degree. But the point in these juvenile glaucoma patients is to find the trabecular, no pigmentation. The exact area is really not easy to find it. But these technique, especially in younger patients, can show us this trabecular area.
Thank you.
Yeah. All right. Thank you so much. So we'll go to the last presentation, and then I would like to just say that for all the delegates who are connected with us, we have delegates connected from over 12 countries, and a lot of them are very interested. So please post those questions onto the chat so that this will be our last presentation, following which we'll be able to answer all the queries. Yeah, thank you so much. And Kirti, it's all yours.
Good evening, everyone. I thank Team IPGS for the opportunity. I'll start with the video presentation.
We can't hear the audio, Kirti.
Is it audible?
Hello, everyone. This is a case of 14 years old female with juvenile open-angle glaucoma. Right eye has hypotonic keratopathy post-trabeculectomy, while left eye has uncontrolled IOP despite medical therapy. Hence, she is planned for trabeculectomy with mitomycin C and tight releasable sutures. The surgery is done under general anesthesia. A fornix-based conjunctival peritomy is done superiorly with optimal hemostasis achieved using wet field cautery. An accidental stab with a number 11 plate caused a scleral wound with aqueous leakage, which was repaired using 10-0 nylon suture. To minimize the risk of hypotony and address the scleral wound, we opted for deep sclerectomy. A 4 by 3 millimeter superficial triangular flap, about 1/3 scleral thickness, is dissected 1 to 1.5 millimeter into clear cornea. 2 to 3 mitomycin C soaked sponges are applied to the scleral bed, avoiding the area of stab wound for a short duration, then removed and area is irrigated well with saline. Then, a deep scleral flap is dissected within the margins of the superficial flap to deroot the Schlemm's canal, extending about 1 millimeter into clear cornea. Here, we note very minimal aqueous percolation, that too more posteriorly than what is routinely seen, suggesting posteriorly dragged Schlemm's canal, possibly attributed to stretched limbus. Hence, another deeper scleral flap is very carefully and gently dissected. In the video to the left, we can appreciate that the inner wall of Schlemm's canal is held by fine forceps and is peeled off the underlying trabeculum. Now we see aqueous percolating from the trabeculodescimate window, which separates anterior chamber from subscleral space. That is, deep corneoscleral block is excised to deroof the Schlemm's canal, and inner wall of Schlemm's canal and juxtacanalicular trabecular meshwork is peeled to expose the trabeculodescimate window. The superficial scleral flap is now closed with a 10-0 nylon suture that is placed to just oppose the scleral flap. Also note that AC depth has been maintained during the entire procedure. Watertight closure of conjunctiva is achieved with 8-0 Vicryl suture. Post-operatively, the patient is started on topical antibiotic eye drops for 1 week and topical corticosteroid drops in tapering doses for 4 weeks. So, non-penetrating deep sclerectomy reduces intraocular pressure via filtration through the trabeculodescimate window into the subscleral space, thus minimizing risks of ocular hypotony, shallow AC, etc. Thank you.
Thanks, Keerti. That was a crisp and a very beautiful presentation. Yeah, so we can take questions. Teresa and Nader Bayumi.
I would just like to point out a question and a comment. The question is, would you combine this procedure with trabeculotomy at the edges of the dissected deep scleral block? And this is the question, and the comment is, sometimes JOAG is an open angle and sometimes it is associated with a similar goniodysgenesis. So if it is an goniodysgenesis, I don't expect find that excellent aqueous percolation. So the condition to conclude the surgery and close should be based on the surgeon seeing this good aqueous percolation and not just dissecting open the Schlemm's canal. I think so.
Yeah, thank you. I think, yes, that's a very, very valid point. And deep sclerectomy is something that we don't have so much of experience with, and we only started doing it in the past maybe 1 year or so. So you have much more experience than this. So which
It
means
doesn't work. It doesn't work well in the Eastern type of, as you've mentioned, not the Western type of childhood glaucoma. It doesn't do that much because for two reasons, I believe. The first reason is that the pathology is mostly pre-trabecular. And the second reason is, of course, the extensive conjunctival fibrosis and healing, especially that you don't use a space maintainer, as you've showed us in the excellent video. Very, very, very nice video and very nice done surgery. But there's no space maintainer, so there's nothing to prevent the superficial flap from adhering to the underlying tissue. So it doesn't appear to work that much in the non-Western type of childhood glaucoma, as far as I'm experienced. I don't know.
All right. Thank you. Yes,
Thank you.
Teresa, please.
Yeah, thanks for this beautiful video. We don't do this technique very much in the United States, so it's wonderful to see. Usually for juvenile open-angle glaucoma, we may start with angle procedures, but of course has variable success rate, maybe even 50% success rate. But the next surgery after that would usually be a trabeculectomy. So again, thanks for showing this beautiful video.
All right. Yeah, so that brings us to the end of all the presentations. So we are open now for questions, and if there are questions in the chat box, we can take them. Otherwise, I think we can discuss among the panelists if there are anything that, some of them we had rushed in between. Sorry for that.
Just to highlight to all the audience the importance of central corneal thickness measurement. That's it.
Yeah. Yes, it is important, especially in certain conditions. It is definitely important, like differentiating a CHED or possibly in glaucoma in aphakia and pseudophakia and things like that. Yes, so can we have the questions from the chat posted here, please? Mr. Jain? Yeah, in the meanwhile, are there any other questions from the panelists or any discussion for any of the speakers, any of the presentations?
I don't know if Dr. Ria Ratna is there. I mean, Ria is there or not?
Yes, sir.
Yeah,
Ria, hi. Ria, I just have one question regarding this genetic counseling, because invariably, the gene that you're associating with the disease may not be so. In a lot of cases, you get pathogenic variants, and they do not, they might not explain the disease, or in some cases, it might be totally unrelated to the disease. In which case, I mean, how do you go about counseling the parents and all? I mean, for example, I had this family, very typical of what you presented, where both the parents had a heterozygous CYP1B1 mutation. The child had congenital glaucoma with a heterozygous CYP1B1 mutation. And now they wanted to know whether the next child is going to have the disease or not. I mean, they wanted to, go ahead with a second pregnancy. So in this kind of a scenario, how would you kind of give a counseling?
So in scenario like this, there are a few points. So during pre-test counseling, for example, if we have a strong clinical diagnosis, I will usually mention the success rate of that particular. So, for example, our anterior segment dysgenesis, like a Peters anomaly and such, will not. Only about 50% cases get diagnosed with genetic testing. So, I will mention that there's a high possibility that nothing shows up in the report. But yes, a clear-cut primary congenital glaucoma, also I will say we are quite likely to find something, and then but there's always a possibility in genetics that we don't get the complete answer. Post that, if in a scenario like this, that there's a heterozygous variant, it fits phenotypically with exactly what we were looking for and the genotypes there, but only partially. There are a few steps. If there's no recurrence risk estimation involved, we will usually not push the patient to try to find the second variant. But if they want to plan another child, I will ask the lab for the raw data files. I will have it looked at by another lab. This is just a cost-effective approach. A lot of people will just repeat the test again at a different lab. Make sure that make sure what kind of panels you're doing, whether it is it's an inherited glaucoma panel versus the clinical exome. What is the coverage of the gene in that? Usually they'll make an appendix and they will write whether it's 100% covered or 99%. Even 99 would probably warrant that it gets reevaluated at a different lab where it's 100% covered. If it's a SIP1B1, I found out that you can test it by Sanger, which is gold standard and cheap. So I would find a lab that does Sanger for SIP1B1 to look for that second variant also. Despite all this, if it still comes back negative, often we are stuck. A whole genome is both expensive and I mean, people are not doing it for clinical reasons, only for research it's being carried out. But there are programs like Gangaram does a program in which if you have a phenotype and you have done an exome and it's negative, they will do a genome sequencing on research basis. So for your non-affording or such patients. So I will try to find out programs like this if you want to really get into it. But one has to draw a line at some point if you don't get an answer from all these also.
Thank you.
Thank you. So we have a couple of questions. We have about 5 minutes to go. So Dr. Leela has a question. Does goniotomy work in juvenile glaucoma?
Not really, Sirisha. I mean, actually, a lot of these angle procedures may not really work because the outflow collector channels and the outflow channels are quite collapsed. And therefore, even if you do angle surgeries, it will not open up those channels, and therefore they will not work. So the success rates are pretty low. But there is a group of juvenile glaucomas that are amenable to angle surgeries. I mean, I would say it is about 30 to 70%. Like 70% will not work, but there's a chance that 30% will work. And it is very difficult to predict which ones. So what we do is we do ASOCTs. We look at, whether we can visualize the Schlemm's canal or not. And if on high definition ASOCT, we find that there is a Schlemm's canal there, we expect that the outflow channels would be good, and therefore the angle procedures would be functional and therefore would work. So that, yeah.
Thank you. Anyone else has any difference of opinion?
No, I'd just like to add that eye-stent surgeries, usually they don't advocate for juvenile glaucomas. So I think it's the same premise that if the angle is very immature and you suspect the outflow channels are going to be affected, maybe it's not a good idea to try eye-stents in these eyes.
Yeah.
But there are reports of KDP goniotomy being fairly effective. So since it's an angle surgery with an early or moderate glaucoma, perhaps you can give it a try. But I'm not sure how effective it is.
Yeah, I have a similar experience. I usually do offer a goniotomy first, as opposed to doing a trab first. And I almost rarely have a patient or family say, yes, we'd like the bigger surgery first. So almost always I just tell them up front, the smaller surgery has a 50-50% chance of working. But with the full disclosure, knowing that when it does work, it doesn't always last very long and they may eventually need a bigger surgery. But I think if the family and the patient are aware of the lower success rate, they're usually pretty happy at least to delay a bigger surgery for a while.
All right, thank you. So there is one question on how much dilution of trypan blue is necessary to identify the Schlemm's canal. I
don't think we, we've done a lot of studies where trabecular meshwork we tried to stain. We don't need to dilute it at all. I mean, we use the same amount that we use for anterior capsule staining to stain the trabecular meshwork as well.
Yeah, but with a caveat that we need to be careful that we don't stain the crystalline lens in these young patients. Yeah, so there's another question. I think the last one is in aphakic glaucoma, where already we have a higher central corneal thickness. Should we take the CCT into consideration while recording the intraocular pressure or understanding what is the target pressure?
I think the WGA consensus did mention that although the CCT is thicker in children with aphakic glaucoma, you don't take it into consideration when you decide to treat. So that's what the consensus statement says.
May I make one small comment here, please?
Yes, please.
Sometimes I totally agree this is the consensus statement, but sometimes you get really extreme numbers of CCTs. I have actually photographed the console of the machine because no one will believe that I have crystal clear corneas with thicknesses of 800 microns, 900 microns, and I have actually photographed 1000 and 1100 microns, crystal clear corneas. So I agree that I would not take into consideration a CCT of 600 microns or 650. Of course, this is not to be considered. But we do see crystal clear corneas with CCT as thick as 800, 900, and I dare say I do have 2 or 3 photos, 1100 microns thickness cornea. I believe these are definitely to be taken into consideration, and I would consider the level of cupping of the optic nerve or the optic nerve changes as indicative of the condition, in addition to the IOP with the CCT. I think so, yeah.
Yeah, agree with you. And of course, axial length and the refractive status of myopic shift and things like that also have to be considered before one decides on just the intraocular pressure. All right, thank you so much. And I would hand it over.
Sirisa, before you conclude,
yes,
one small comment on the case which Rasmi presented, the phacomatous pigmentovascularis 360-degree trabeculotomy with good result. Theoretically speaking, the etiology of glaucoma, one important component is raised episcleral venous pressure. So even when you are doing trabeculotomy 360-degree, you are not taking care of that component of raised episcleral venous pressure. So this is probably an ideal indication where, in spite of doing trabeculotomy, even if it is 360-degree, probably addition of trabeculectomy is a theoretical concept. That's what I believe. What others feel about it?
Agree with you, Dr. Mandal. So if not today, at some point in time, they may have an elevation in intraocular pressure, which is like additional components, because you cannot say it's the angle dysgenesis. You can have multiple mechanisms for glaucoma.
Yeah, the question is which etiological component is contributing more to the pathology.
Yeah. Thank you. Thank you for bringing it up. Dr. Manju, all yours.
Yeah. Good evening, everyone. I really appreciate the time spared by all in attending this 4th annual IPGS meeting virtually. Our sincere thanks to our international faculties, Dr. Teresa Chen and Dr. Bayomi, for actively participating in this meeting. And a sincere thanks to our extended and honorary member, Dr. Arif Khan, who has shown active interest and has attended in all our meetings, both virtually and physically. We appreciate Dr. Sumita, Dr. Ria, and Dr. Gaura for their excellent talks. And our sincere thanks to all our members of GSI who are actively supporting this specialty. Mandal sir, Shanta ma'am, Sushmita, Sirisha, and Vinay needs a special mention for their enthusiasm in spite of their very busy schedule in discussing about this childhood glaucoma. We also appreciate the active participation from all the presenters and the delegates who had spared a Sunday evening for us. A sincere word of appreciation goes to the Endowed Pharma for their support in this Zoom meet and Numero Uno for the active participation in supporting us with the flyers and the circulation. I hope I have not forgotten anyone else. And we also take this opportunity to invite you all for the next physical meeting in Madurai on December 12th and 13th, 2025. And we are adjourning this annual meeting now. Thank you.
Thank you so
Thank
much.
you.
And
Thank you so
wonderful.
much. Thanks, Sirisha. Thanks, Manju, for organizing this whole thing. Thank you so much.
Yeah, really, really
Thank you
enjoyed
very
it.
much.
And we
Thank you all.
Yeah.
Thank you very much. Thank you for
Thank
having
you
me.
all.
Thank you for an excellent meeting. Thank you very much.
Thank you. Thank you so much, Teresa and Bayumi, for staying on
Thank you.
until late. And for Teresa, it is early morning, so she woke up at 5 a.m. on a Sunday morning to be with us. Thank you so much. And
Everyone next year, right?
The best meetings I've been to. Thank you.
Yeah. Thank you to all the participants who stuck to time, and it really, we're just over time by 3 minutes.
Great.
It's not bad at all. Thank you. Yeah. Thank you so much.
Thank
Bye-bye.
you. Bye. Good night.
Good night.
Bye.
You have to join for the next meeting.
Yeah.
Okay.
Yeah.